Dear guests, dear participants, dear colleagues, and dear friends. Good morning and welcome to our DZNE event on dementia and migration. It is 9 o'clock sharp, but we are still waiting for some participants and registrants. You all know that technical difficulties are still a part even after 1 year of pandemic multitude video conferences. So, however, as a bonus to all of you who made it on time, and also a chance to smoothly go into the topic, we have prepared a short video for your enjoyment that gives you a short introduction on what we have been doing the last 2 years.
I am Jessica Monsees, and I'm a psychologist and a doctoral researcher at the DZNE. And I'm working on the EU Atlas project, not only from the official start in April 2019, but I was already involved in applying for this project.
My name is Tim Schmachtenberg. I'm a sociologist, but I have been working in healthcare research for more than 2 years. And since starting my new work as a doctoral researcher at the DZNE in April 2019, I'm in the field of dementia and migration.
My name is René Thyrian. I'm a trained psychologist and epidemiologist, and at the DZNE in Rostock-Greifswald, I'm leading a working group on interventional healthcare research. This project I conducted together with my colleagues at the DZNE and the University Medicine of Greifswald, funded by the Robert Bosch Stiftung.
If you take the topic dementia, you will see that there is a lot of research going on. You will find a number of studies and you will find quite a lot of information on dementia, but this is not the case with dementia and migration, because dementia and migration is an under-researched topic, and this is not only true for dementia and migration, but also for the broader topic of migration and health.
There are now some studies that suggest that people with a migration background with dementia and their family members use less care and support services. But the question is, why is that? And most importantly, what services would they like to receive? And to be able to answer such important questions, we must first know where do how many people with a migration background with dementia live, and what background do they have?
Well, the biggest challenge is to find people on a European level that adequately represent Europe and the expertise. So we had a big problem finding experts in all countries of the EU and EFTA countries that were able to discuss dementia and migration with us. There was a big challenge in all the different languages in the EU to be really close to what is happening in the country. And there was a big challenge because of the Corona pandemic, because interaction was limited to video, for example.
But the biggest challenge was to prepare a well-structured and illustrative publication from all the data and information we collected on this topic.
Besides the scientific personnel, we also had 2 geographers involved because we wanted to visualize our results. And of course, we couldn't do that, so we needed experts for that. Maren Leitz and Ulrike Stenzel, who are geographers and who are from the Institute for Community Medicine.
Also insgesamt sind es 36 verschiedene Nationen, für die wir die Karten erstellt haben, mit bis zu 10 verschiedenen Kartentypen, sodass wir dann in der Summe auf 248 Karten für den Atlas gekommen sind. Also auf den Karten haben wir für jede Nation individuell die Prävalenzen herausgearbeitet, und wir haben es nicht nur auf Nationsebene herausgearbeitet, sondern, sofern es die Daten zuließen, kann man auch in kleinräumiger Einheit genau nachschauen oder nachlesen, wie dort die Prävalenzen an demenzerkrankten Menschen mit Migrationshintergrund aussieht.
In the creation of the EU Atlas, we involved a very multidisciplinary team. So we started out with psychologists, sociologists, then we saw, okay, we needed geographers, but then when we went to the experts, we went to nurses, we went to economists, we went to policymakers, we went to lobbyists, and so I cannot count all of them. It is truly multidisciplinary.
And all this information that we gathered, we put together, and it resulted in this EU Atlas, in this book with over 500 pages actually, which we were quite astonished by.
For the first time, we have in one document information on the distribution of people with a migration background with dementia in the European countries and individual regions in different countries. It also provides the first insight into the existing care structures at a European level.
This atlas can be a foundation for also politicians, for lawmakers, and for decision makers, so that they can take action and they can create healthcare that is suitable for people with migration background with dementia.
In the long run, we think that this is a small step in pursuing a European strategy for dealing with dementia and migration on many different levels.
And I think I can speak for my whole team that we are very proud of what we achieved with this, that we accomplished our goal and even more with this EU Atlas.
I hope that you are all eager to see what we have accomplished during the last 2 years and what we will discuss and what discussion will be initiated during the next few hours. When we started to announce it, we asked for registration. However, participation is possible without registration. Registered users will get some more information afterwards since we have the contact details. And yesterday we checked our files and can happily announce that we have more than 100 registered users, exactly 115, and they have registered throughout Europe. So we have people from Germany, from Belgium, Sweden, the UK, Bulgaria, Netherlands, Ireland, Spain, Finland, Austria, Italy, Liechtenstein, and just to name a few. The event will be recorded and is available on the internet afterwards, and we would like to have you recommend it to our colleagues and share it as much as you can. It is too bad that we rely on the video format. All guests will participate via video conference. Only the project team is present here at the DZNE. All people have either been tested negatively on corona, have been fully vaccinated, and we comply to the current rules regarding keeping distance and ventilation wherever possible. I'm honored to announce the launch of our EU Atlas on Dementia and Migration, which we incorporate in a bigger event that is focusing more and broader on the topic of dementia, migration, ethnicity, intercultural care, and related challenges in Europe. What can you expect? Funded by the Robert Bosch Foundation and prepared in cooperation between the DZNE, the University Medicine of Greifswald, the Institute for Community Medicine, you will be hearing my colleagues Jessica Monsees, Tim Schmachtenberg, and Maria Cardona presenting the results of our project EU Atlas on Dementia and Migration. We are also honored that Dianne Gove from the Alzheimer Europe will share her work about intercultural care, diversity, and policy. There will be time for questions and discussion. This will be realized by using the chat function you all have access to. The third part is planned as an expert panel session. We have invited experts by experience, colleagues working in the field, European research experts, and policymakers. But before we dig into the topic, I would like to give the word to Dr. Klapper from the Robert Bosch Foundation to officially open the event. Dr. Klapper, we will see you by video. Good morning. Good morning nach Stuttgart. The floor is yours.
Good morning, René. Good morning, everybody. Yes, my name is Bernadette Klapper, and I'm very happy to very warmly welcome you to the Dementia Day today. On behalf of the Robert Bosch Foundation, I'm really excited and delighted that today the EU Atlas, Dementia and Migration, as well as the research on intercultural care and support, will be presented to you. It has been a long research journey indeed, starting in December 2017 for both the Robert Bosch Stiftung as the funding partner, and the researchers and experts of Deutsches Zentrum für neurodegenerative Erkrankungen and Alzheimer Europe. In our demographically changing societies, dementia poses particular challenges due to the large number of people affected. The loss of memory is a key feature of the disease and the lack of cure option to date. According to estimates, the number of people with dementia in Europe will increase significantly in the coming years. While in 2010, almost 10 million people were living with dementia in European countries, an increase of about 40% to approximately 14 million is expected for 2030. Due to the internal mobility in Europe and immigration from outside the Union, the issue of dementia is also becoming increasingly important for older people with a migration background and their families, particularly because there are additional challenges for these people. For example, in the course of the disease, the language learned in the country of destination might be forgotten, or biographical work, which is successful in the case of dementia, is made more difficult because characteristics and customs from the country of origins are not known for the caring team. Finally, access to medical information and the fit between medical and nursing care maybe not be completely satisfactory due to language barriers and cultural differences. Both dementia and migration impact society and interact with others, but very little is known about dementia and migration. There is indeed emergent evidence that a migration background is associated with underdiagnosis or lack of access to appropriate health care. Thus, the care of people with a migration background is a public health challenge. Effective remedies begin with better knowledge of the situation. However, the database on the prevalence and the health and care situation of people with a migration background and dementia in Europe is difficult to access. Analyst-related evaluations of individual European countries are only rudimentary and do not allow reliable statements on the care situation of those affected. The EU Atlas Dementia and Migration of Deutsches Zentrum für neurodegenerative Erkrankungen and the research work of Alzheimer Europe on intercultural care and support will close the gaps in knowledge. For us, as the Robert Bosch Foundation, this is more or less the final part of a long journey of 17 years where we have been busy in the field of dementia and to support the people affected of the disease and their belongings, their relatives and all their families. With today's online event, the research journey and our funding have come to an end. By presenting findings and the results to the public, the first steps is taken in supporting transnational exchange, networking and cooperation between stakeholders from politics, science, practice and professional areas. For the benefit of those affected with dementia and their families, we hope that there are many people and steps to help and steps to be followed. I'm really grateful of the tremendous work and the really interesting results of all our funding partners of Alzheimer Europe, of the DZNE in Greifswald. We're very proud of this day, and we hope that it will enhance and support your work across Europe. This would be really our wish, and then I think we could say that our mission would be accomplished. I thank you very much for your attention, and I hope you will have an exciting and interesting day today. Thank you.
Well, thank you, Dr. Klapper. The Robert Bosch Foundation really has been supportive and enthusiastic about our work, and like you said, the last 17 years of work in the field of dementia. And I think this event will be really reaching out into the stakeholders, into Europe, and see that we can make the next step and really start networking even more with the people already playing in the field. Having said that, I would like to introduce Jessica Monsees, who is starting the first part in really discussing and really presenting the EU Atlas on Dementia and Migration together with her two colleagues. Jessica, please, it's your stage.
Yes, thank you very much, René, for this introduction. My name is Jessica Monsees, as René said, and my colleagues Maria Cardona, Tim Schmachtenberg, and I, we are going to present you the EU Atlas and a few selected results that we have generated. And here you can see our journey throughout this project, and this will also guide our presentation for today. And first off, we want to give you a little bit of a backstory of this project and the topic dementia and migration before we then present you with the results. And I'm going to start off with our results on the estimated numbers of people with migration background with dementia in the EU, EFTA, and UK countries. And then Tim Schmachtenberg will talk to you about the analysis of national dementia strategies and national guidelines. And then Maria Cardona will present you our expert interviews and the analysis of healthcare services before we then, in the end, reveal the atlas itself. And it all started out with the general idea of the Robert Bosch Stiftung to generate more knowledge about prevalence data of dementia in people with a migration background. And we applied to do this. We then got together with the Robert Bosch Stiftung. We talked about it. We developed this idea even further, and we brainstormed on how to approach all of this. But why did we do that even? As Dr. Klapper just stated, it's a fact that, or it is expected that the number of people with dementia is expected to rise in the coming years and decades in Europe. And people with a migration background are a subgroup of special vulnerability because they do not only face the dementia-related healthcare challenges as the non-migrant population does, but there can be additional challenges. And these might be challenges because of a language barrier or because of a low familiarity with the healthcare system, the healthcare services, or the general lack of culturally sensitive healthcare services provided to them. And another thing that we can say is that dementia in general is underdiagnosed, and this can be more pronounced in people with a migration background. And there's also the fact that dementia-related healthcare services are used to a lesser extent by people with a migration background. And it is so important to have a diagnosis, to receive a diagnosis of dementia, because this is an important first step to receive appropriate treatment and care. Because right now what we can assume is that people with a migration background with dementia and their family members, they're not being taken care of, or they're being taken care of in a way that is not tailored towards them and their needs. And recent analysis showed us that there are an estimated 468,000 people with migration background with dementia living in the different EU and EFTA countries. So we can not only say that they are a vulnerable population, but also a group of a considerable size. And although there is more and more research going on in dementia and migration, it is still an under-researched topic. For example, we do not really know how the different healthcare systems in all the European countries, how they take care of people with a migration background with dementia and their families. Another thing that we see is that there are more and more countries who publish national dementia plans, but as far as we know, there is not a comprehensive overview that tells us how people with a migration background are considered in this. And the same goes for national guidelines on care, treatment, and diagnostics. And this is where our project comes into the picture. Because what we set out to do is that we not only wanted to estimate the number of people with a migration background with dementia, we also wanted to break that down by different countries of birth. We wanted to show where the people actually live in the countries, and we wanted to visualize this. We further wanted to analyze the national dementia strategies and guidelines on care treatment and diagnostics to see how people with a migration background with dementia are considered in this. And then we wanted to know how experts view the situation in their respective countries and how the healthcare systems and the healthcare services, how they consider people with a migration background, how they take care of them. And our overall aim with this is to provide a source of information to policymakers, to decision makers, but also to people working in the field of dementia and or migration, and to relevant stakeholders in that field. We also want to raise awareness for a very important topic, for a topic that needs and deserves more attention. And we further hope that we can encourage further research in this area. And as I said in the beginning, this all started with a call of the Bosch Stiftung in October of 2018 that we applied to. And then in November of that year, we met up with the Bosch Stiftung, we presented ourselves, we presented what we would like to do with this project, what our approach would be. We were then chosen by the Bosch Stiftung to do this, to conduct this project, and then we officially started in April of 2019. And until October of that same year, we really worked out and we really determined the final work packages and the procedures that we wanted to apply to achieve our goals. And in October of 2019, we did a workshop with experts from the field of dementia and or migration at the Alzheimer Europe conference that year, where we presented our project and our plan, and we were hoping to get feedback. And based on the feedback that we received, we adapted what we planned on doing. And then from October 2019 until March of this year, we were really busy with our analysis. We did all the interviews. We wrote all the chapters that are included in this atlas. And then from March until June, we were then busy with the revisions of the atlas. We were busy with the layout and the printing and creating a website that goes along with this atlas. And we are proud to say that now both the atlas and the website, they are done, so that today we officially have our launch day for both. But of course, there is no study without limitations, without challenges, and we wanted to address some of those right away. One thing that surely can be discussed is our definition of a migration background, because we define that as a person who permanently does not live in the country that the person was born in. Another challenge that we had is that finding people who identify themselves as experts on dementia migration is difficult, because it is such a relatively new topic. And then when we gathered data on people with a migration background age 65 or older, we saw that there are a lot of differences in this data. There are differences between the healthcare systems of a country. And then when we take a look at the national documents, we see there was a high heterogeneity in the scope, in the languages and the content. But with that being said, this atlas still is a valuable source of information, and now we are coming to the part where we are presenting you the results. And as I said, I'm going to start with our estimations on the number of people with migration background with dementia. And what we did is that for each country that we included in this atlas, we obtained data on the number of people with a migration background aged 65 or older from different countries of birth. And we got that from the statistical offices of the countries or Eurostat. We then needed age-specific dementia prevalence rates, and we took the ones from the World Alzheimer Report provided by Alzheimer's Disease International. And we then applied these prevalence rates to the people with migration backgrounds. And to make it a little bit more clear, what we did is that, for example, for people who were born in Algeria, that are aged 65 or older and that live in France, we took the dementia prevalence rates of France and applied that to the people who were born in Algeria to determine the number of people with dementia from Algeria living in France. And we did that for the whole country, but we also did that for the NUTS 2 regions of a country, if a country has these NUTS2 regions. And if you're not familiar with the NUTS system, let me very quickly explain it to you. The NUTS system is a system that subdivides the European countries into 3 different levels. And level 1 represents the largest areas of a country, and then the level 2 divides these large areas into smaller areas, and level 3 subdivides these smaller areas into even smaller units. And then after we were done with our calculations, we wanted to visualize that. And our colleagues from the Institute for Community Medicine created maps in 2 different categories. The first category shows us the number of people with migration background with dementia, and we're showing the absolute number. And we're showing that on 3 different levels. We have the European level, where we have an overview over all EU, EFTA, and UK countries. Then we have the individual level of each country, and the national level, I'm sorry. And there you can see the 5 most common countries of birth for each country. And then we take these 5 most common countries of birth and we are showing you in which NUTS2 regions the people actually live in. And another thing on the NUTS2 level, we show, again, for each NUTS2 region, the 5 most common countries of birth. Then we have our second category, and that is the proportion of people with migration background with dementia per 100,000 inhabitants aged 65 or older. And this is also something we show on the European level, the national level, and the NUTS2 level. And now we want to start off with the absolute number of people with migration background with dementia. And on this slide, you see the European level, and our estimations show an estimated 531,000 people with migration background with dementia all over the EU, EFTA, and UK countries. And looking at this map, you can say that the darker the blue, the more people with migration background with dementia live in a country. And the countries that are estimated to show the highest numbers of people with migration background with dementia are Germany, France, the UK, Switzerland, and Spain. And if you consider all EU, EFTA, and UK countries, then the migrant groups that are estimated to be mostly affected by dementia, they originate mostly from Italy, Algeria, the Russian Federation, Germany, and Poland. To show you the maps that we created for each country, we chose Spain as an example. And here you can say that people with a migration background with dementia, they are estimated to mostly originate from the United Kingdom, from Germany, from Morocco, from France, and Argentina. And for these 5 countries, we show you where the people actually live in Spain. And we show that for Algeria. And here again, the darker the region, the more people live there. And you can say for people originating from Argentina that are estimated to have dementia, they mostly live in Andalusia, Madrid, the Valencian community, and Catalonia. And here you will then see for each NUTS2 region the 5 most common countries of birth in absolute numbers. And you will notice that the countries, they differ from region to region. For example, if you look at the Balearic Islands, then people with dementia, they mostly originate from Germany, from the UK, Argentina, France, and Morocco. If you take a closer look at Galicia, then people mostly originate from Portugal, from Cuba, Argentina, Brazil, and Uruguay. If you then take a closer look at Aragon, for example, then you will see it's mostly France, Romania, Morocco, Argentina, and Peru as countries of birth. And another thing that you can notice is that we have countries that pop up in different regions of Spain, like Argentina. You will find that as a country of birth in different regions. But then there are other countries that only show up in 1 or 2 regions, like Brazil. Now we come to the second category of maps, and this is the proportion of people with a migration background with dementia per 100,000 inhabitants aged 65 or older. And we start off with the European level. And here you can say that the countries with the highest estimated proportion of people with immigration background with dementia, age 65 or older, are Liechtenstein, Luxembourg, Switzerland, Latvia, and Estonia. For Spain, the proportion, what you can say here is, for example, that per 100,000 inhabitants aged 65 or older, there are an estimated 84 people who were born in the United Kingdom and who are estimated to have dementia. Or there are 17 people who were born in Argentina and who are estimated to have dementia. And here on this slide, you see the proportion on the NUTS 2 level. And the size of the pie charts, they indicate the proportion. So the bigger the pie chart, the higher the proportion of people with immigration background with dementia is in that region. And you can say that for a region like Ceuta and Melilla, there is a higher proportion of people with immigration background with dementia per 100,000 inhabitants age 65 or older than in regions like Galicia or the Principality of Asturias, where the proportion is much, much smaller. And to sum that all up, we can say that our calculations and our estimations, they confirm that people with a migration background with dementia, they are a group of considerable size, and we have to take care of them. We need to take care of them. And this is something that needs to happen on different levels. And one of these levels is the policy level, and how people with a migration background are considered on a policy level. This is something that my colleague Tim Schmachtenberg is now going to talk to you about.
Yes, thank you, Jessica. And yeah, as my colleague said, I will now continue with a summary of the chapter on the national dementia plans. And in this analysis, answers should be found to the questions to what extent special needs of people with a migration background with dementia are identified in European countries, whether specific actions are taken at the national level to ensure their care, and how attention is paid to the relationship between dementia and migration. To get answers to these questions, a qualitative discourse analysis of the national dementia plans and strategies of the EU, EFTA, and UK countries was conducted according to the model of Rainer Keller. The online platform of Alzheimer Europe and the search engine Google served as a database for these documents. These databases were screened on 2 dates, the 1st of June in 2019 and the 4th of January in 2021. As a result of this screening, the data corpus comprises 38 documents. These documents were systematically screened for their relevance to migration. The first step was to examine whether the documents included separate chapters on migration. And then the national dementia plans were screened for several K-terms, such as minorities, migration, culture, ethnic background, or migrant. This means that ethnic, language, and cultural minorities were also considered in this study, as migrants are often part of these so-called groups and were then no longer explicitly mentioned. In national documents on dementia care, many different terms are used for people with a migration background, which we have tried to identify as completely as possible. If the migration topic was found, a content analysis of the section in which it was located was carried out. For this purpose, the contents were paraphrased, memos and comments were added, and the text passages were coded using the strategy of open coding. Afterward, the results were interpreted and assessed. Based on our search, 18 of 27 EU, all 4 EFTA, and the 4 UK countries have a national dementia plan or a national dementia strategy. Of these 26 countries, 14 countries address migration in their documents. A separate chapter on dementia care for people with a migration background is only included in the Austrian dementia report and a German dementia strategy. The majority of the other national dementia plans address the topic only briefly. The content focus on a section on migration was primarily on the description of the challenges related to the care of people with a migration background with dementia. The most frequently addressed challenges are cultural and language barriers, late diagnosis, and low utilization of healthcare services. Overall, 10 countries refer in their national dementia plans to planned measures to care for people with a migration background. Attention shall be paid to the conception of tailored information materials, training of caregivers, and the development of language and culturally appropriate diagnostic tools. Yeah, and as seen on this map, only the documents of Germany, the Netherlands, Northern Ireland, and Norway refer to available services for migrants with dementia. The German dementia strategies refers to various counseling services tailored to people with a migration background with dementia and their relatives. According to the Dutch document, special attention has been paid to in the early detection and prevention of dementia. Northern Ireland has developed a self-assessment tool for service providers that contains a whole questionnaire with items around the topic of migration. And Norway's dementia plan cites a project completed in 2020 that adapted test procedures for assessing cognitive abilities and dementia symptoms to foreign languages. Overall, this analysis has shown that the topic of migration plays only a subordinate role in national dementia plans and strategies of EU, EFTA, and UK countries. Yeah, and in the second document study, analysis of national treatment and care guidelines, policies, and recommendations on dementia with regard to people with a migration background was conducted. The national dementia care and treatment guidelines of the EU, EFTA, and UK countries were analyzed with the same methods as the national dementia plans. These documents were obtained with the help of the national Alzheimer societies, national health or social ministries, and different professional societies. The organizations were contacted by email in the period from the 2nd of May to the 11th of July in 2019. Responses were received from 47 organizations of 35 countries, and thus it was possible to create a profile for each EU, EFTA, and UK country. To integrate documents from as many countries as possible, no definitions or restrictions were made. Besides, a Google search was conducted. The final corpus of the documents for this analysis was 43 documents. To structure the very heterogeneous corpus, the documents were assigned to the standardized categories policies, guidelines, and recommendations. According to this analysis, 20 of 27 EU countries, 4 EFTA countries, and all 4 UK countries have documents with national recommendations, guidelines, or policies of the care of people with dementia. 15 documents from 7 EU countries, 4 UK countries, and the EFTA country Norway discuss the topic of migration in these documents. Norway and Sweden have their own chapter in this document, on migration in this document, and Northern Ireland also addressed this topic in detail in its guidelines. Most other countries refer only briefly to specific aspects around this topic. The thematic focus of the documents is on early detection and diagnosis. The main challenge identified is that the cultural background and acquired language skills of people with a migration background can influence the results of dementia diagnostic tests. Consequently, the content focus in most countries is on the suitability of cognitive screening tools for people with a migration background. 7 countries identify that people with a migration background have specific needs. They refer to a different perspective on dementia, different preferences for care, and other desires regarding information and self-determination. 9 countries provide recommendations for the care of people with a migration background with dementia. Several countries recommend that the linguistic and cultural background of people should be considered when selecting diagnostic test procedures. Yeah, and now as seen on this map, only Norway, Sweden, and Denmark refer in their guidelines to available healthcare or diagnostic services for people with a migration background with dementia. Norway cited published information material on dementia in 4 different languages and a brochure with information on the provision and use of professional interpretation services. Sweden and Denmark point out that the intercultural dementia screening tool RUDAS has been validated for people with a migration background. Similar to the study of the national dementia plans, this analysis shows that migration plays only a subordinate role in the national documents on dementia care. Yeah, and overall, 90 documents on the care of people with dementia were considered in this analysis, of which 38 contain migration references. The proportion of national dementia plans has increased slightly due to the integration of documents published in 2019 and 2020 into the corpus of this study. But migration is still a minor topic in the national dementia plans, strategies, and guidelines for the care of people with dementia in most European countries. Yeah, and now, after giving you an overview of the extent to which the topic of migration is considered in documents on national dementia-specific care planning and what strategies countries have or do not have on paper to care for people with a migration background with dementia, let us now look how the situation is in practice. Which European healthcare system have a specific focus on a migration background of person in the care for people with dementia? And Maria Cardona will address these and further questions concerning the care practice in different European countries. Thank you.
Yes, thank you, Tim. So for the final stage of the project, in addition to the previous work that it was presented, also we decided to conduct all these qualitative interviews with experts in the topic of dementia. Why? Because for us was very interesting to really get to know further views on the topic, and also we wanted to receive in-depth responses on how the care situation looks like in practice in the included countries. So the original plan that we had for the interviews was to visit the experts in the respective countries and then have these interviews face-to-face. Nevertheless, the pandemic, COVID-19 hit, and then we also had to change the format of our interviews due to all the traveling risk and also the traveling bans. And at the end, we have to conduct the interviews via video conference. So we use the Zoom platform, and then we use it for the course of 12 months. So after saying that, we also can have an overview of the methodology we implemented. So it's very important to start telling you that we conducted semi-structured interviews, and then here we were basing our questions in 5 main topics. So the first one was general aspects for persons with migration and dementia. Also, we wanted to explore how was the care provided for persons with migration background. Also, we wanted to explore how was the inclusion and the information provided to this population. We also asked in the interviews regarding the professional care. And finally, we explored the topic of support for family caregivers. It's also important to mention that the primary source that we use also to design all these questions from our interview, we consider the Alzheimer's Europe report from 2018, and also we had a look on further literature on dementia and migration. The language that it was used most of the time, or most of the interviews, were held in English. Nevertheless, we had 3 exceptions: Liechtenfels, also Germany, and Luxembourg. And the participants, they were experts, and these experts, they were researchers, care planners, care providers, and also representatives from the different Alzheimer's associations. And here, finally, we can say that the data analysis method that we used was a qualitative content analysis. Another important topic that I would like to mention for the methodology is that we designed this interview guide that you can see right now on the slide. And like next to it, we also designed a document with the key terms, and we also provide a definition of them. And both documents were sent to experts before the interviews, and then they could be prepared for our interviews. Or also, if they have some questions, they could communicate with us, and we could solve these questions before we held the interviews. So this is one example, and then we can see like on the blue square, like the first main topic we explored, which was general questions on dementia and migration. And also then you can see two of the questions. This is just an example for you to familiarize a bit with the interview guide that we decide. So one question is, according to your opinion, how important is the topic of dementia and migration in your country? Then the second topic that we also explored was care for persons with migration and non-migrants with dementia. And also there you can see some examples for the questions. The next topic that we explored, or that we wanted to talk with the experts, was inclusion in healthcare and information of persons with migration background. And one of the examples for the question is, could you please estimate the level of inclusion of persons with migration background with dementia into healthcare in your country? Then we have professional qualifications and also persons with migration background working in healthcare. And here we ask the experts, like, according to your opinion, is culturally sensitive care part of the professional qualifications? And finally, the last topic that we discussed with the experts was support for family caregivers. And one example of the questions is, how high do you estimate the need for specific information and services to family caregivers of persons with migration background and dementia? So after having this overview of the methodology and the kind of questions we pose to our experts or to our participants, these are some of the results we got. So first, I can say that we conducted 18 interviews, 2 written statements, and 1 discussion group with 26 experts from 17 countries, the ones that you can see on the slide. And here we can also mention that we faced 2 main challenges. First, that we didn't include as many countries, experts from the many countries as we expected, because it was hard to get response from all experts from all the EU and EFTA countries. And the second challenge was that the experts that we included, not all of them were experts in dementia and migration. Why? Because in some countries, dementia in migrants is not a relevant topic of study. So at the end, our experts, some of them, yes, they were experts in dementia and migration, but others, they were just experts on dementia or experts just on migration. But even though saying that, we do believe that we collect insight and meaningful responses or results from our experts, and that's what I want to share with you in the following slides. So here we can see the 4 main aspects we discussed with the experts. So here we talk about general aspects on people with migration background and with dementia. So we wanted to identify how important is the topic dementia and migration in the included countries. And also we wanted to identify with this main topic if persons with migration are considered as a vulnerable group with a specific needs. So as you can see in the first graph, just 1 country mentioned that the topic is very important in their country, and the majority mentioned that this topic is partly or rather unimportant. Also, we can see that in the majority of the countries, this population is considered as a vulnerable group. And also when it comes to identify people with migration background and dementia, like the majority said that sometimes they are treated as a group with a specific needs, but also like 1/3 is saying that never or rarely they are treated as a group with a specific needs. The second topic that we also discussed with the experts, it was care for persons with migration and also non-migrants with dementia. And here we wanted also to discuss like how available are services, are care services for persons with migration and dementia in outpatient and inpatient care, and also the suitability of those existing services. So the first two graphs are indicating us that most of the countries are divided like between not available, and also if they are available, the services in outpatient and inpatient care, they're available just in single regions. And then the third graph is asking for how suitable are these services. And then the experts said that yes, that they are suitable, that they exist, but only for people without migration background. Here, this is our other topic of discussion with the experts, and here we were exploring the inclusion and the provision of information to people with a migration background and with dementia. And here by inclusion, we also, we mean participation from this population, but also if they are included when this, for example, care services are being designed or if they're being enhanced. And most of the countries said that not at all, that this population is not included, and also like a big proportion said that slightly or partly. But none countries said that always they were or that they were included. Another topic that we also explore is professional care. And here we ask the experts to estimate the proportion of healthcare workers with migration background. Again, in inpatient and outpatient care. And also we wanted to know if the need of culturally sensitive care was being met by sufficiently qualified professionals. So we can see in the first two graphs like similar results, and we can see that the proportion of healthcare workers with a migration background is between high and very high in outpatient and inpatient care. And also we can see that the need of culturally sensitive care is not being met by sufficiently qualified professionals. And finally, the last topic that we also discussed with our experts was the support that is given to family caregivers. We wanted to see if there were differences in the information and formal services providers for family caregivers of persons with migration background and non-migrants. And most of the experts said that there were no differences between the healthcare services providers between these two groups. So now, after we have seen the results, we want to tell you the main conclusions, for the interviews we held with our experts. So we can say that first, that there is a great lack of attention, particularly from society, also from science, and from care policy. And in most of the countries, there are no specialized services for persons with migration and dementia. And most of our experts also mentioned that it's a big problem because they see that there is a need for those kind of services. There's also a big need for culturally sensitive care, and that, as I said before, is not being met by sufficiently qualified professionals. And also, family caregivers of persons with migration background, they are using less frequently, the formal services. So maybe, or perhaps, this is happening because these specialized services, they don't exist. So the final point that we can conclude is that the relative high proportion of health workers with migration background is also a great opportunity for the future of care with this population. Also, as an overall conclusion for our project, we can say that persons with migration background and with dementia and their families, they represent a large group, but also they are a heterogeneous group through all Europe. Also, there are significant differences between all the regions that we included. We can say as well that migration is playing a subordinate role in the national dementia plans and also in the dementia care and treatment guidelines that are offered in all the different regions that we included. Also, we can conclude that there is a need for inclusion and improvement in the current healthcare system. and that intercultural needs, they need to be improved in both, in inpatient and outpatient care. One remark is that the EU Atlas is systematically addressing, like, all of this is for the all EU country states, the EFTA countries, and also for the UK. And even though we also do believe that we have these meaningful insights, our results, they need to be interpreted with caution. First, because the EU Atlas is not a benchmark for countries, or it does not define what is appropriate or adequate or not. Also, it is based on data available to the team, so also better data is needed on all levels. Also, the Atlas does not serve the purpose of an in-depth state-of-the-art, because we were making a standardized and a systematic overview across Europe. And also, we have to think that our Atlas, it has like a validity that cannot be describing always the real situation due to the lack of sufficient participants and like the experts and in the interviews. And finally, we can say that the Atlas is focused on migration defined as a person not having a permanent residency in the country where they're living. So saying that, we can say that that's like the end of our project, and now we want to pass to the most exciting moment. We want to reveal the Atlas, and we want to present it to you.
So, dear colleagues, we want to do it. We want to share this special moment with you, and I would like to ask my colleagues and thank the colleagues, Jessica Monsees, Tim Schmachtenberg, and Meri Cardona on the stage, and to finally get the work presented to all of you. It is available from now on, and we could only just have a glimpse of what is in there. And I hope that you will all look for it and read more into it when you see what it actually is. It's nothing that you can put under your pillow, but it's something that is worthwhile just looking around. In German, we say schmökern in it. So, let's now the festivities going on, and please be prepared. Look at the faces of all of. There is pride, there is fun, there's relief, and basically we are very happy to present it to whole Europe now, and Jessica is having the biggest task to show the EU Atlas. So, here you can see it. It is more than 500 pages, it is heavy, and we want to able to present all of it. You can scroll through it, and like Jessica has said, we have maps for each countries. You recognize them now. We have the expert interviews Maria was talking about for all countries in here. We have the methodology section here, and it is a really nice thing we are proud of. There will be versions in French. There will be versions in English and German to ensure that it's available for as much people as possible. As this cannot be sent to all participants, DZNE would probably be very poor after sending them to all people interested. But we have integrated this information on our interactive online internet tool, so you can scroll through the atlas and look at maps, look at all the interviews on the internet page of the DZNE. It will be shown in the videos, the link to this atlas. There will be a PDF version that you can download, and please don't print it out, but read it. And thanks again to all contributors, especially Ulrike Stenzel, Maren Leitz, Nanja Vandenberg and Wolfgang Hoffmann from the University Medicine Greifswald, the participating and contributing experts from all countries, and the Robert Bosch Foundation, Dr. Klapper and Brigitte Stähle for really supporting us. Now, take a breath. I hear you all applauding in front of your screens, and that's thank we didn't have dance or anything is not allowed here. But resting for a second, enjoying the moment, and moving on. Since we think it's well-deserved and good, but like mentioned before, The atlas is a starting point, or one piece in the big picture. Our next speaker is Dianne Gove from Alzheimer Europe. We are honored and eagerly awaiting her contribution. She will broaden our horizon and enlarge the topic from migration up to a higher level on more ethnicity, and she's presenting her work on the development of intercultural care and support for people with dementia from ethnic minority groups. And she will also address the policy needed to achieve adequate intercultural care. Feel free to comment in the chat section. I've reached some have reached me per email and asked some questions, so there will be a discussion afterwards, as there will be time for questions and comments. Dianne, I can see you on the screen. You're well prepared, and we are awaiting your talk. It's yours.
Okay, thank you very much, René. Good morning, ladies and gentlemen. My name is Dianne Gove, as just been mentioned, and I'm the Director for Projects at Alzheimer Europe. And I also chaired the work carried out since 2018 by a group of experts in the domain of intercultural care and support. And I'd just like to, before I start, to thank the organisers, DZNE, for having invited me to present this work today, and also the Robert Bosch Foundation for their continued support for all this work on this topic, very important topic. I'm going to first provide you with some background information about the work that the group has produced, which consists of a comprehensive report on intercultural care and support, a policy statement, a database of initiatives for intercultural care and support of people with dementia, and a guide or handbook for social care workers. And as I present this work, I'll be highlighting some of the key messages that we wanted to convey to different stakeholders who play a key role in ensuring that people from minority ethnic groups have access to good quality and appropriate care and support. So with regard to background information, Alzheimer Europe felt that it was important to address this issue as part of its efforts to promote and protect the rights of all people with dementia in Europe under the general heading of inclusion and within the context of ethical concerns, for example, linked to respect for personhood, dignity and non-discrimination. And this is particularly relevant because, as we've already heard from Jessica, the number of people with dementia in Europe with a migration background is considerably large, and it is also increasing. And there's a relatively low uptake of dementia care and support services by people from minority ethnic groups. And yet at the same time, there's no widespread and systematic recording of the number of people identifying with specific ethnic groups who are using or not using services. Person-centered care, which is often considered as the gold standard for dementia care, is not really possible without cultural awareness, sensitivity and competence, which are the building blocks of intercultural care and support. And in addition, willingness and motivation, as well as support from policymakers and funders, is needed. Also, governments have a legal and moral obligation to ensure equity in the provision of support and care, again based on respect for autonomy and non-discrimination. We chose to focus on minority ethnic groups as a slightly broader group than migrants, and we defined this broader group as including people who share a common cultural identity which differs from that of the majority ethnic group, regardless of whether they have direct personal experience of migration or not. And the reason for this was that people from minority ethnic groups do not all have a direct experience of migration, but often face some of the same or similar issues as those who do in relation to dementia care. So I'll go into a bit more detail about ethnic groups later when I talk about the guide. With regard to culture, Ardila described three different aspects. First, the internal subjective or psychological representation of culture, including thinking, feeling, knowledge, values, attitudes, and beliefs. Second, the behavioral dimension, including the ways to relate with others, ways of behaving in different contexts and circumstances, festivities and meetings, patterns of association. And then third, the cultural elements, which include the physical elements or characteristics of human groups, such as symbolic elements, clothes, ornaments, houses, instruments, and even weapons. Interculturalism, Our approach to care and support was based on a definition taken from a 2015 report by an association called Age Action for All Older People. And I quote from this report: "Interculturalism is essentially about how we interact, understand, and respect each other. It's about ensuring that the cultural diversity of a population is acknowledged and catered for, so that minority ethnic groups are included by design and planning, not as an add-on or an afterthought. An intercultural approach recognizes and encourages people's freedom to keep their identities alive, supporting all cultures to flourish together and share their heritage. It sees difference as something positive that can enrich society and recognizes racism as an issue that needs to be tackled in order to create a more inclusive society." To develop intercultural care and support to people with dementia and their carers from minority ethnic groups was one of the overall challenges and the desired impact of the overall work that's been carried out. It's also important for clinicians to have access to appropriate, culturally sensitive and validated tools to provide accurate and timely diagnosis to all people with dementia. And it's also important to ensure that people from such groups know about dementia and would know if they or a relative were showing signs of possible dementia. They have access to timely diagnosis as well as appropriate, good quality services and support adapted to their needs and those of their entourage, and would know not only where and how to access services, but would actually find them appropriate and would want to use them if they felt that they were necessary. And for health and social care professionals to have the means and opportunities to develop cultural awareness, sensitivity, and competence. And before going any further, I'd just like to show you the members of the working group who carried out all this work since 2018. And the members were invited to join the group on the basis of their expertise in different areas of relevance to the provision of intercultural care and support. So that included, for example, experience in evaluation and diagnosis, linguistic issues, working with specific ethnic groups, research in this issue, and the development and provision of services and support. And unfortunately, not everybody is on this photo, which was taken at the first meeting at the University of Bradford. So we're missing Jean-Georges, who took the photo that many of you know, Jessica and René, who joined the group later, but you've just seen them, and also Debbie from Israel. Some members of the European Working Group of People with Dementia were also very helpful in making links and identifying initiatives for the database in their countries, which I'll talk about later. And we discussed the topic in this work with our member associations, so national Alzheimer associations, on 2 different occasions at public affairs meetings. So that's the group. The working group explored the literature and shared experience working with and for people with dementia from minority ethnic groups. And this resulted in a comprehensive report addressing awareness raising and promoting help seeking, ensuring timely diagnosis and treatment, support and care, and professional and informal carers. An important issue to consider is how people from different ethnic groups perceive and talk about dementia and how this may affect help seeking. In some languages, there's no word for dementia, at least not in everyday language, and some health and social care professionals prefer to use the term dementia, sometimes translated into the national language, in combination with an explanation about what the term means, even if it doesn't exist in a particular language. In most languages, however, there are everyday terms for dementia, but these often have associations linked to being forgetful, obsessed, or confused, having a mental disorder or having reverted to childhood, or just being a normal part of aging, which is quite a common perception. And some of these terms, however, are euphemisms, but some actually suggest mockery or are clearly derogatory. And when trying to raise awareness about dementia and promote help seeking, a key message that we wanted to convey was that dementia can be perceived and experienced and named by people in very different ways, and that different perceptions are not problematic in themselves or restricted to certain minority ethnic groups. However, in some ethnic groups, people don't see dementia as a medical condition at all, and if they also lack access to culturally appropriate information, that's understandable to them, then they might miss out on the medical and social care, treatment and support that other members of society are benefiting from. So looking at some of the ways of understanding dementia, if dementia is considered solely as a natural part of aging, it may be concluded that nothing much can be done about it. Considering typical symptoms of dementia as signs of normal aging may lead to people accepting certain behaviours, and this may reflect continuing respect for people with dementia and not seeing them as a problem. But it can also mean not seeking outside help, as I just mentioned. And this is especially likely in communities where the family is the central unit of importance and where there are very strict cultural norms and traditions about how to respect and care for older relatives. If dementia is considered as a test or punishment from God for something that they or members of their family have done wrong, then it may be considered most appropriate to consult a religious leader rather than seek medical advice or support. On the other hand, it should be acknowledged that religion and spirituality can be a valuable source of support and mental strength. Perceptions linked to the result of poor care or neglect or mental illness, especially of a hereditary nature, may not be conducive to help seeking, as there may be concerns about the reputation of the family linked to shame on the family, jeopardizing marriage prospects and the reputation of the wider family, even beyond the country where people are living. And this can be a strong deterrent against help seeking. When it comes to communicating about dementia and promoting help seeking, information must be culturally appropriate and understandable, and people must also be able to actually relate to it. And this is linked to the issue of equity in the sense that it can't be said that everyone has access to the same quality of care or support if information about it is not accessible and understandable. Culturally appropriate channels and means of communication must be developed and used to reach people with dementia and carers from minority ethnic groups. And this should include, for example, written materials, but also face-to-face and audio-visual approaches, materials targeted at specific minority ethnic groups, images which reflect typical life in those communities, so photos of or images of environment, scenes of people that are familiar, and using examples that people from those communities can really relate to. And this requires the involvement of people from minority ethnic groups in the development of culturally appropriate materials and messages. And efforts should be made to build up trust within minority ethnic communities before and as part of a proactive awareness raising campaign or initiative. As Mohammed from our working group stated in an earlier report, it's important to be proactive so as to avoid hard to reach becoming easy to avoid. And the following are some examples of various approaches that were reported in the UK and the Netherlands. So, for example, holding roadshows in areas with a high population of people with minority ethnic backgrounds, facilitated by people from the community and having the relevant language skills, including people with dementia, carers, relatives, and members of the community. Also reaching out to people in community centres, places of worship, sheltered housing and daycare centres, and through community radio stations such as Radio Ramadan and Radio Haji in the Bradford area. Reaching out to family carers by ethnic bilingual professionals in community volunteer centres, and starting co-creation processes with them. Making initial contacts before broaching the topic of dementia and consulting relevant respected members of the community, and providing a dedicated healthcare professional to provide information about dementia. It's important to avoid seeing certain factors which interfere with awareness raising and help seeking as being inherent in the individual, and thereby considering people and groups of people as a problem, so to say. So people are not the problem because of issues related to language literacy, health literacy, and levels of education. Similarly, these issues are not limited to people from ethnic groups. Rather, service providers and healthcare systems have a responsibility to provide for a wide range of people with different characteristics and needs. Also, there are broad political, historical, economic, and social factors which contribute towards the issues and potential differences between minority and majority ethnic groups taken as a whole. And it's important to avoid stereotyping or overgeneralizing and reducing difficulties with language literacy and education to specific groups. And it's also important to recognize the possible experience of prejudice and discrimination at the interpersonal and structural level, as well as the intersection of different factors. So, for example, linked to gender, socioeconomic status, employment, and housing. Ethnicity is unlikely to have an impact on pathological processes underlying the appearance and evolution of dementia syndromes, and the symptoms of dementia seem to be similar across different ethnic groups. The diagnosis of people with a migration background remains problematic, however, and yet some medical conditions are more common amongst some minority ethnic groups, such as diabetes, vascular problems, hypertension, depression, and stroke. So there may be actually a need for extra vigilance with regard to dementia. Nevertheless, many people with a migration background are not being referred by GPs. They're receiving a substandard diagnostic workout and no specification of the type of dementia that they have. And despite the role of biomarkers, dementia is still very much a clinical diagnosis, and consequently, any difficulties in communication between clinicians and patients are likely to affect assessment and diagnosis. And there's a lack of culturally sensitive assessment and diagnostic tools, although progress is being made in this domain. Culturally inappropriate and insensitive procedures and tools, as well as difficulties for many people with language literacy and education, may result in inadequate assessment and diagnosis for many people from minority ethnic groups. People who didn't have much formal schooling when they were younger may function less well in some evaluation and diagnostic tests. And it's not so much about lacking knowledge, but more about people not being used to being tested. Also, people may be less familiar with writing or using computers, have difficulty with reading, writing, and following instructions in the context of tests, and not familiar with issues covered in tests. They may also lack certain facts and sometimes also not see the point or importance of answering questions in the test situation. People should be assessed in their best or preferred language, but there's often a shortage of professionally trained interpreters at the times when they're needed. And the use of relatives can be problematic, and volunteers need to be properly trained and supported. Interpreting is a highly skilled profession, and also it's important for everyone to understand the role of interpreters. Person-centered care and support is often considered as the gold standard for care and should, according to the 2010 Swedish National Board of Health and Welfare guidelines, involve consideration of the different cultural or linguistic backgrounds and needs of people with dementia. I'm drawing here on a translation from Antelius and Pleasure. The board further stipulates that respecting cultural needs should be interpreted as giving people with dementia disease the opportunity to practice their religion, being served culturally appropriate food, keeping their cultural traditions and customs, and having access to nursing staff that communicate in the same native tongue as the person with dementia. However, this shouldn't, and clearly in this context, isn't a simple box-ticking exercise. It was further specified in the document that there should be nursing staff who are able to communicate in a person's native language and who also have cultural competence. And this is the important bit, to give people with dementia, with different ethnic backgrounds, a sense of security, increased well-being, and a sense of feeling at home. A relationship-centered approach is also important, and that it reflects the interdependence between people with dementia and formal carers, and the importance of interpersonal interactions, also with families and close friends, in creating a basis for care and support. We looked at the issue of mainstream versus specialised services for particular groups, and there was relatively little information on the topic. But what came over was that there was no consensus on what was best, and it was not about whether people access every day to traditional food or to carers who are fluent in their language, but more about how that all comes together in the resulting atmosphere of care, whether that be mainstream, which could be more challenging to achieve, or specialised. It's generally considered that there's a lack of uptake of services from people from minority ethnic groups. And some of the reasons for this include lack of trust in the healthcare system, stigma, including discrimination, in some cases not just linked to dementia, services considered as inappropriate, so they're not corresponding to people's wishes or respectful of people's cultural needs, although there could be other services that people would appreciate that haven't been developed. The whole issue of perceived responsibility for care within some communities, which reflects cultural traditions and is often based on gendered roles. And this is linked to the issue of pride, honour and shame, in the sense that families in some communities feel it is not only a duty or obligation, but also a source of satisfaction and an opportunity to give back the love and care that parents and older relatives gave to them when they were younger. And this also comes back to the issue of tests and punishments from God and the desire to be seen as accepting these. And there are also financial issues and the belief sometimes that a person can be better cared for at home. The focus on improving intercultural care and support also needs to explore issues related to the well-being of carers. So professional carers from minority ethnic groups and migrant carers, informal carers from minority ethnic groups, and live-in carers. There are several issues and challenges here, such as the lack of cultural awareness and training, ethical dilemmas and structural constraints, stigma, prejudice and discrimination against professional carers for those who are migrants or who identify with a minority ethnic group, acculturation and both formal and informal carers from minority ethnic groups, sometimes feeling caught between the demands and expectations of different cultures, the vulnerability of and lack of proper protection and support for live-in carers, in some cases the lack of health insurance, no pension contributions, insufficient time off, blurred boundaries between being a member of the family and being a professional carer, isolation, residency rights, language barriers, and in some cases not knowing where to turn for help. There's also the issue of parallel care responsibilities of live-in and some migrant carers in the home and host country. So they may have dependent relatives at home, such as school-age children, older people and disabled people, and the home population could also be missing out on good care workers. I now turn to our policy statement, which was aimed at reaching out to some of the people who have the potential to make decisions which can bring about positive change. People with dementia from minority ethnic groups encounter barriers at individual, societal and structural levels. And governments and policymakers have a moral and legal obligation based on the principles of non-discrimination, human rights, beneficence, non-maleficence, and respect for human dignity and personhood to ensure equity in the provision of care and services. And equity in this context means ensuring that people of all ethnic groups actually receive appropriate evaluation, treatment, care, and support, and not that there are standard provisions based on the needs and wishes of the majority ethnic group, which everyone is free to use. That's not good enough. Governments, commissioners, service providers, and health and social care professionals in Europe, they're not all at the same point with regard to developing or providing intercultural care and support, and they don't all have the same resources or structures in place, and they're perhaps also not at the same level of awareness of the importance of developing intercultural care and support. So the expert working group developed a policy statement outlining the main issues with broad recommendations targeted at policymakers at different levels, so local, regional and national. And I'm now going to just give you some of the examples of these. So first, sorry, just get a drink. First, to develop culturally sensitive health and social care materials about dementia and available care and support. To use appropriate channels of communication. To promote health literacy amongst people from minority ethnic groups. To create incentives for health and social care professionals and take disciplinary action when necessary, for example, in the case of discrimination. And to promote ongoing practical training and awareness raising about ethnicity in the health and social care sector. To ensure that assessment and diagnostic tools are culturally sensitive and validated, not merely translated. To give people the right to be assessed and diagnosed in their own or best language, which might not necessarily be their mother tongue. To make it a right to have access to an interpreter if needed for assessment, diagnosis, and care decisions, and to agree on standards for professional interpreters and intercultural mediators, including appropriate training curricula and accreditation, and to establish guidelines and restrictions for the involvement of lay interpreters, as well as support. And to promote cultural diversity in research by involving people from minority ethnic groups in research funding programs, requiring their involvement in research ethics committees, and encouraging people from minority ethnic groups to become involved in dementia research as participants and in the context of public involvement and as researchers, and taking measures to increase the number of bilingual or multilingual staff working at all levels in the health and social care profession. We're asking governments to make a commitment, we're asking governments and policymakers at different levels to make a commitment to and invest in intercultural care and support, thereby contributing towards a healthier population in terms of mental, physical, and social health, the creation of jobs, the retention of informal carers in the workforce, avoiding the cost of managing crises, and avoiding premature institutionalization. And that's not just about a financial issue, that's about people's lives. And to formally enshrine such commitment in relevant policy documents. And so that's why we've included wherever possible. Sorry. Yeah, I'm getting mixed up with my slides here. So whereas the report I mentioned earlier was aimed at providing a comprehensive overview of issues that are relevant to the provision of intercultural care and support, and the policy paper was about raising awareness of policymakers accompanied by specific recommendations in the sense of a call to action. With a database, the working group turned to the more practical issue of supporting various stakeholders with regard to this overall goal. The database contains information and a wide range of initiatives and materials. And we actually have an up and running website already, and the database is there. But since the beginning of the year, we've been updating it with the aim of having a more extensive and more sophisticated database. And we currently have 332 initiatives, including, for example, websites which also collect information about different resources, video clips, regular events and support, leaflets and brochures, and non-academic reports and support for evaluation. And these initiatives, they haven't been rated or screened for quality. And the reason for this is that the idea is to improve access to different initiatives, not necessarily to be taken up and used as they are, although that could sometimes be very helpful and useful, but as ideas and a solid basis for the development or improvement of services and support in Europe. And that's why we've included, wherever possible, the contact details for further information. So the name of a person, organisation, email address, and website. And we hope that people using the database will see something that they can either use or adapt, but also that they would contact the producers or organisers of the initiatives for further information, for example, to discuss how they were developed and any challenges or any problems with the development of the actual initiative. And so the revised database is due to be launched in early December, around the time of Alzheimer Europe's annual conference. And although we've officially finished collecting initiatives, we will be continuing to add resources until then, and even afterwards to periodically update and repair any broken links. So if anybody in the audience has examples of initiatives they would like us to share in this database, then please don't hesitate to get in contact with Alzheimer Europe. And finally, on this slide, you can see the different options for the searches. So it will be possible to search for initiatives according to ethnic group or community, the target group, the title and language of the initiative, and the type of the initiative. So it could, for example, be possible to do a combined search for videos for people with dementia and carers in Polish, or printed materials for the general public in Arabic. So you can combine the different search factors. And finally, an important part of this ongoing work was to reach the people who provide hands-on care and support to people with dementia from different ethnic groups. The expert working group set out to summarize the relevant information from the comprehensive report and to make it more accessible to social care workers who may have different levels of education and types of training, and also already be working in direct contact with people from minority ethnic groups. And the term used to describe this group of people may be different in different languages and care systems. But basically, we wanted to target the people who provide care and support directly to people with dementia from different ethnic groups regularly or daily at home, in daycare centres, or in residential care settings. And so this would include everybody coming into contact with people with dementia. So, for example, social care workers, care staff, cooks, cleaners and drivers, everybody involved. And the guide draws on the original report that I mentioned earlier by the Alzheimer Europe Working Group, and also on a shorter report by the Nordic Welfare Centres Theme Network, which was also inspired by the forum. And the guide has been translated into from English, into French, German, Italian, and Bulgarian. And we worked together with professional translators, our member associations, who also included volunteers, and staff at Alzheimer Europe to ensure the accuracy and the right terminology and tone of the translation. So the aim of the guide was to help social care workers to provide dementia care which corresponds to the needs and wishes of people from a wide range of ethnic groups, especially minority ethnic groups. It's not a recipe book for success, but rather an attempt to provide useful information and to motivate and empower social care workers to develop cultural awareness, sensitivity, and competence. There are no ready-made answers because every situation is different and involves different people at different moments in time, in different countries, with different health and social care systems. On this slide, you can see the different chapters of the guide. With regard to minority ethnic groups, we emphasize that ethnic communities are made up of people who have things in common, such as language, religion, traditions, and values that make them feel part of a group. And for many people, ethnicity is a fundamental aspect of their identity, of who and what they are. And it's not the sum total of what a person is or who a person is. People have multiple intersecting and overlapping identities, and there are communities within communities. It's not something that's biologically determined, and not everyone who identifies with a particular ethnic group agrees with all of its principles and values or practices all its traditions. Groups are formed through an ongoing flexible process with individuals and groups adapting to each other without this necessarily threatening their personal identity, culture, or sense of belonging to the group. So ethnicity is not something that only other people have, and it shouldn't be perceived in terms of them and us. I mentioned earlier the issue about different perceptions of dementia and how this can affect service use. Different cultures may also have different beliefs about the role of the family in people's lives. In some cultures, families have a central role in that social norms, personal attitudes and behaviours are defined, expressed and judged with the interests of the family at heart. And this could be described as a we culture, and it's based on shared principles and values, which include showing respect to older people, obeying parents, and taking the mutual responsibility for each other. And this is quite different to the individualism of the I culture, which is more common in majority ethnic groups in Europe, where the emphasis seems to be on principles and values reflecting personal autonomy, independence, and the interests of the individual. Of course, I've described this in the form of two ends of a continuum, rather extreme, and people are not completely at one end or the other. It's a common view in many European countries that people from minority ethnic groups look after their own, it's often said, and don't want support. But this can actually make it difficult for some people to seek help, and some people don't have children or other relatives to support them, or they don't want to be supported by them. Carers may sometimes feel frustrated when support and services are not taken up, and this might even seem to confirm the belief that people don't want or need help. But it's much more likely that such support and services are not culturally appropriate or sensitive, or that people don't know about them, don't know that they're entitled to them, or other reasons mentioned earlier. And care workers may sometimes find it difficult to accept gender divisions if they're not familiar with that. And in some ethnic communities, a male relative may be considered as a spokesperson and decision maker for the family, even though actual care is predominantly provided by women. And the women with hands-on responsibility for the provision of care may sometimes be reluctant to seek support for fear of being criticised, for not being able or willing to provide care, or of letting the family down, not overlooking, of course, the satisfaction that many people, that often accompanies that role. So the challenge is to find ways to provide support that's acceptable to all concerned, to take up any opportunity offered to talk to members of the family directly providing care, but also not to try to change people's beliefs and practices, and not to exclude the person with dementia. It may sometimes be helpful to frame the offer of services and support for carers to provide the kind of care that families would like to provide, rather than as ways to relieve them of their responsibilities, and in daycare or residential care, to work with families to try to find ways to involve the family. And some of the everyday things that are important to people from all different ethnic groups could be, for example, being understood and able to communicate with others, food, drink, hospitality, and forms of respect, clothing, celebrating festivals, practicing traditions, and for many also practicing a religion. Language may be a big barrier, but it's not an all or nothing matter. Many people who've lived all their lives in a particular country are able to speak and understand the national language, but not perfectly, especially in some situations, women who have not had paid employment and the opportunity to use the national language every day in the workplace. And this can become problematic when combined with language impairments that are common with dementia. And within some communities, there may be subtle differences in language use, for example, different ways to express emotions, to speak to older people, to express friendliness or respect, and to talk about parts of the body. And this is not always obvious, but of huge importance when it comes to providing respectful and good quality care and support. And for people who acquire a language later in life, for example, after having moved to Europe, this can be a further challenge because the last language is usually the first to be affected, and the first or original language might not be spoken by many professional carers. So we emphasize the importance of multilingual staff, non-verbal communication, supporting carers, and making an effort to learn a few words or phrases, more in the sense to communicate acceptance and to promote inclusion than particularly for practical issues. So some of the key messages: cultural awareness, sensitivity and competence can't be learned solely from a book or from a one-off training course. It's an ongoing process of learning and exchange between real people. And for this reason, dialogue, including non-verbal communication, is crucial. And one of the messages we had was, if unsure, it's important just to ask. Inter and intra-group differences are important to bear in mind when developing services which are not only culturally sensitive, but also respond to the needs and wishes of individuals. In drawing attention to issues that are important to people from one or more specific groups, there is a risk, as I mentioned earlier, of overemphasizing difference, of stereotyping, and thereby jeopardizing the right of people from all ethnic groups to care and support that's truly person-centered. So we really wanted to emphasize that awareness and acceptance of cultural difference doesn't need to overshadow recognition of the many things that people from all ethnic groups have in common. And it can and should provide a solid basis from which to explore the needs and wishes of each person. Every person with dementia is unique, and it's important not to lose sight of the individual. And an overall message or thread throughout the guide, and indeed all the work, has been to try to find the right balance between attention to cultural factors and influences and attention to the individual as a person in their own right, regardless of any ethnic group that they may identify with. So I'd like to thank you for your attention, but I'd also like to acknowledge and thank the Robert Bosch Stiftung for their continued support from 2018 to 2021, which made it possible to prepare with the expert working group all the work that I've just presented now, and also to thank the European Commission for their initial support as well in 2018 for the report. Thank you very much.
Well, thank you, Dianne. Yes, I'm a little bit speechless, like always, when I hear your tremendous work and the talk you've given. You have touched so many issues, and when we discussed this already in the audience, in our little team here, some questions came up to our mind that we would like to ask you or elaborate a little bit more on. Let me say first, basically what I think is the key messages could be: read the report first and read it really thoroughly. Then for all the people working in the field, read the guide you published and participate in collecting data. And there it already goes into a question. So one sentence you said that led to discussion is that no consensus could be reached what is best. This is difficult because we would like to have a clear guideline. Tim might add something to discussion. Well, we are just focusing on migration, limited definition. You're saying, well, it's ethnic minority. Then we have experienced in the EU Atlas, there is not just ethnic minorities, there's also indigenous people. So could you reflect a little bit more about all those phrases? How important are they really, or are we really going back to the roots of individualized care? So could you spend some words on this?
Yeah, I think I'm not sure whether the comment I made on no consensus was in relation to the mainstream or the specialized care.
The specialized care.
Yeah, taking that as an example, one of the things that we found was that when we actually looked at the different possibilities, it was more a question of having to bear in mind also what people need, but also what is possible and what can work within a particular healthcare system at a particular moment in time, and also very much linked to resources and opportunities. And that when I say that there was no consensus, I didn't specifically mean between experts, although that's also the case. But I think there needs to be a broad range of service provision which meets very different needs of people, and that it wouldn't be possible to say that everybody wants the same kind of care and support. And I think this applies across all ethnic groups. And for example, with regard to specialized care, it depends on a person's background and life and experience and their way of life prior to needing that kind of support as to whether that would be really what would suit them as an individual, actually be totally immersed within the kind of the tradition, the culture of a particular minority ethnic group, because maybe that doesn't reflect their lifestyle. Maybe they have been brought up in a very multicultural environment. So I think it's a question of having a range of services and support that then take into account people's different cultural needs and wishes, but also that take into account the fact that people are also individuals, and that ethnicity is not the sum total of a person's identity. And that was one of the main issues that we wanted to communicate, is that we haven't to lose sight of the individual. And I realize that's a very complex balance to find. And funnily enough, now we're just starting, Alzheimer Europe is just starting to work on the issue of gender and sexuality. And one of the issues that we will be addressing there is a little bit similar, is to the sense of there may be specialised daycare centres or residential care centres for people who are, say, gay or lesbian. And then again, there's the same debate. Is that kind of singling out certain identities or aspects of a person's identity? Is that a good thing or a bad thing? But it all depends at the end of the day as what do people actually want, and what is the kind of support and services that they would find suitable. And I think that's what we have to develop.
Okay, thank you. There was also a question about, well, you supposed people should be qualified to be cultural sensitive, and you said that the report gives some hints. Is there a real, or can you tell the audience whether there is a qualification course available? How can people be qualified, or do they have to look into their national healthcare systems? So is there some person, some institution, or you can say, go there and then you learn intercultural care?
Well, I should just say, first of all, that this is the work based on the literature and consultation with the group of experts, and that we didn't carry out as part of this work an overview on the different actual practices and kind of arrangements in each country, and that would have been a very useful task to do, but that wasn't part of the work. But what I would say is that with regard to cultural sensitivity and awareness and competence, that's kind of linked to another of the points that I was making, that it's not something that can be it's not something that can be learned from a book or a training course, although obviously guides, books and training courses are very important, but it's really a question of developing this kind of sensitivity and awareness through working with people, through guidance. And I think that it would be good to have some kind of a framework which could perhaps highlight the different aspects that should be addressed, but at the same time it comes down to people and to interaction. And it wouldn't be possible, for example, to say, okay, so I've done a course on intercultural care and support, so now I'm qualified. I don't think it's a question of qualification. I think it's a question of also of a mindset and a set of skills which needs to be developed over time. And it's the constant getting to know people from different cultures to one's own, and it's this ongoing exchange. And so I think that's what's important there.
Okay. Well, thank you. And another question to the database was, you were saying that there is lots of information in different languages available, like, for example, pamphlets and things like this when you did the research. Is this available in the database, or is there, if someone is interested in having Turkish information material in Germany, where does he get it if he doesn't get it from Germany? What is this? Is the database the source to get it?
Hopefully. Well, the point of developing the database was that we realized that there's a lot of information out there, but that it is actually difficult sometimes to find the information in the different original sources. And so we wanted to bring it all together in this database that we're developing and currently in the process of refining, so that people will be able to come to the Alzheimer Europe website, go straight onto the database, type in, as I said, the different kind of search criteria. So that could be information for informal carers from the Turkish community about a particular topic or about dementia in general. And then that would take people directly to the original source. So in a way, it's a kind of, I don't know what you call it, like a kind of a gatekeeping system where we're sharing the information that's already out there. It's not information that we've produced ourselves. And throughout the whole database, one of the things that is important is that for each entry, it's recognized which organization or individual produced the information, and then the person is taken to that website, or there could be, for example, a link actually directly to the document. Originally, I'm sorry, we had not usually talk so much. Originally, we had the actual documents on our website as PDFs, which is kind of useful in the sense that you can then access directly the information, and if the links are broken, then there's no problem. But we felt it was important also to actually send people, direct people to the original source, and then there could be additional information there. And one of the challenges for us, which we were prepared for, is to actually make sure that the database is constantly checked, that the links are definitely safe, that they're not out of order or anything like that. And so I think that it is really a question of directing people to what's out there. And there's a huge amount of information out there. We've been limited to a certain extent by, we've been trying to access different sources of information, but at the same time, we're limited by our own linguistic abilities. So that's why we really need support from some of the perhaps the members of the audience and other researchers to actually direct us to some of the resources that we don't have, to make sure that we cover as many different communities as possible.
Yes, thanks. Yes, the linguistic barriers we saw too in the documents we were researching, and the amount of data and the amount of knowledge we gained, even though with this project. So, who is funding this, and whose task is it to really provide this information, to make it available, to keep it up to date? Is this the Alzheimer Europe, or who should be this on a European level? What do you think?
Well, I can only speak from the perspective of the work that we're doing on our database, and that work has been funded by the Robert Bosch Stiftung, to whom we're very grateful. And without that funding, we wouldn't have been able to do this. And that was for the original database, and also for the revised version that we're working on now, which will be launched, as I say, in the beginning of December. We've kind of collected the information that's on there from the members of the expert working group, whom I mentioned earlier, and also from actually just actively looking on the internet and from different organizations for different information. We've also had some very good support from individuals, researchers who've sent us information. It's a task that we'll be carrying on doing even beyond the extent of the funding, because it's been so great that we've had this funding to create this database now, that it is something we have to really keep going over time. I'd just like to mention that Belize Budak from the DZNE, she was doing a secondment with Alzheimer Europe, and she spent a lot of time looking for new initiatives which have now been inputted. And my colleague Grazia Tomasini, she's had the terrible job of transferring all the information from the old system onto the new one. And so, yeah, basically it's an ongoing task, and I think the main work has been done originally and just recently with the help of Belize and Grazia. And I think that's something that as an association we'll need to ensure that we keep on top of that. And as I say, any help from outside, for any direct, if you could just direct us to certain sources even to follow up on, then we would be very grateful for that.
And one question about the thing we have discussed too was, well, you're talking very much about ethnic minorities in the people to be cared for. When we looked in the EU Atlas, we saw that the challenge of dementia and migration across Europe is different from region to region. So there is the Western, very stereotypical now. There is the Western region, basically having the demographic change problems, having lots of people, migrants there that are there in their first, second, third generation, older people. And there's the East region where the demographic change is different, because there the workforce is leaving. And this workforce is working in the Western part. So tell me something about the cultural or the ethnicity challenges in people providing professional care, like 24-hour services from Poland in Germany. Is this considered in the report, or what are your thoughts about this?
Yeah, that was that's in the last section of the report, where we actually look at professional carers who are from minority ethnic groups. That's in the broader sense, and also more in the direct sense of people who migrate to, say, Western Europe or Eastern Europe actually provide the care. And so we do actually considering in quite detail in the report, and it is worth having a look at that section, about some of the challenges that are encountered when people move to Europe to take up a job as a professional carer, linked to, for example, the discrimination that they experience within the workforce and from the people to whom they're providing care. Also, the issue of qualifications. They may be qualified in a certain domain, and maybe that's not transferable when they arrive in a different country to provide care. But also the difference that when I was talking earlier about different perceptions of dementia and different perceptions of care, that can also be a bit of a cultural shock when people come in from outside of Europe to take up a care profession in the care industry, where they have different perceptions of care than is in currently kind of like the ethos of a particular organization. And that can be quite difficult to adapt. And I think in that case, it's very important that migrant carers have the support that they need in order to kind of to adjust to the system and to understand the way that things are done, but also that there's an exchange, that there's a lot that everybody can learn from each other amongst professional carers and in that particular context. And then we had quite an extensive section or debate in the report about live-in carers and about the kind of the difficulties of moving from one country to provide care in another. And even though people have personal care responsibilities in the country that they have left, and those people are still there, and that also, as I think you mentioned, that the actual communities from where the people leave, they're actually losing some very valuable and important people who could provide care within that community. So there's a bit of an ethical issue there as to, you know, the loss of the qualified workforce in that particular country. And then also some of the issues that I mentioned about live-in carers, because it's a kind of, in most countries, it's not particularly regulated. And so there's quite a risk to the people with dementia of lack of proper healthcare support, feeling isolated and cut off from their own culture and not being able to integrate into or to adapt to the country, also linked with language issues. And even like pension contributions, if somebody's not fully recognized within the system, as time goes by and people spend a lot of time as live-in carers, later on, they're not going to have those same pension contributions that they would have had had they been in regulated profession.
Well, thank you, Dianne. That's we started out with a very small project about counting people, and then we end up in a very complex situation by now, touching all kind of issues and all kind of regions, and it's hard for me to somehow sum up the whole thing. Since we are at the end of the question and answer section now, and I want to leave you all in a short break for approximately 10 minutes or so, to think about perhaps some questions arise, and we can answer or touch on those in the next session, in the third part, where there will be the expert session. Just think about the things and look where it's going. What we are doing for the last session will be, we have invited some experts by experience that have a very personal focus. For example, people that are really working in the field with ethnic minorities or that are from an ethnic minority themselves. We have some specialized researchers there, and we have a policy maker invited to participate in the discussion round. So, Dianne, thanks a lot for giving this huge talk, this broad topic, and stay tuned, please. And all of the others, please come back in about approximately 10 minutes and for the final expert session with our panelists. Welcome back to the final part of our event, a discussion with experts from the field. We started with presenting the EU Atlas that was basically a first step to approach the complex issue. Then we tried to give a systematic overview, but focused on migration. We saw that even on such a rather superficial and rather descriptive approach, it becomes clear that there is quite a diversity. The overall conclusion was there is need for action on many different levels: research, policy, healthcare, and so on. Dianne Gove, with her presentation, has already shed some more light into the complex issue. She broadened our horizon in regard of migration as one of the many facets of basically acknowledging the individualized need of each human and acting appropriately. She has put it on a higher level. The discussion afterwards has then already shown that there are many issues that need to be, and many fields of action that need to be accomplished. But now it's time to give the opportunity to more experts in the field to comment or add detail, and in the best case, even though the format is a little bit limited on that, to discuss some of the most pressing or urgent topics. I'm happy that we were able to get Gülec Isik-Dirim as expert by experience to participate in the panel. To give an example on the perspective on the community level, we invited Rauf from Meri Yaadain and the University of Bradford, who has and will talk about his experience in work with ethnic minorities on the community level. Rune Nielsen from Denmark is an expert when it comes to the challenge of assessing cognitive status, cultural fare, or in population with diverse backgrounds. Our participant number 4 is Sadia Parveen from the University of Bradford, UK. She has been conducting research along the whole trajectory from diagnosis to palliative care in people from minority migration backgrounds. And I'm very much looking forward what aspects she will pick out from all the things we have been mentioning already. And last but not least, but not present yet, we are happy that Sirpa Pietikainen, a member of the European Parliament, will join us. We have seen that action is needed, and she will be able to comment on what is currently being done and what could be done in the future. I will give each expert the opportunity to introduce him or her and talk about the topic from his/her expert view and perhaps already react to some questions. Then we have the opportunity to discuss in between. So let me first move to Gülec Isik-Dirim, our expert by experience. Since we have heard many experts by now who look at dementia and migration from their professional perspective, it is important to give time to understand this complex issue from the perspective of people directly affected. While this is more and more called for, it's not easy to find people who participate in such sessions. We have heard from Maria's talk early that recruiting is a challenge. We have heard it from Dianne that having access to people being affected is problematic. And I'm glad that we were able to get in contact with Gülec and do very much appreciate her joining us today. She's from the Netherlands, born in the Netherlands, and has been caring for both of her parents who migrated from Turkey. In preparation for this meeting, we met by Zoom, and I already have learned a lot. But I will stop now talking to give the floor to you, Gülec, more time to tell your story. Please take some minutes to introduce yourself, you and your experience.
Okay, thank you very much. I feel honored to tell the story of my parents today here and to share my experiences with you. I am Gülec, the youngest daughter of Musa and Shazia Dirim. Musa was my father. He came to the Netherlands in 1965. A few years later, my mother joined him, and they had 7 children in total. 3 of them still live in the Netherlands. Me and my younger brother are the ones that saw my parents grew older, developed chronic diseases, and later on got dementia as well. And as the years pass by, they become more depending on us, especially on me. So I've been a caregiver for more than 20 years now for my parents. I feel as responsible for my parents as I do for my daughter. My youngest daughter is 15 years now. And the roles have changed during the years. Now I am the one that decides what's in their best interest, and their suffering from chronic diseases and later on dementia became my struggle in organizing suitable home care, eventually in finding a nursing home where they could get the professional 24 hours care they needed and where they would feel welcome and at home. Well, that was a great and nearly impossible challenge for me. And it was a very difficult and tough decision to make. They got isolated, but I felt isolated as well. So in order to keep them safe together and to prevent an involuntary admission, I organized their admission together to a nursery home where they had the experience in cultural sensitive care for migrants with dementia. I had to move my parents for 3 times in a period of 5 years. And at the beginning, they were, I moved them to a place that was almost 2 hours away from the city where I lived, because there they had the experience on giving care to cultural sensitive care to migrants with dementia. And in the beginning, that felt great. It wasn't a burden taken away from me. I could be a daughter again, and they were taken care of in the way they should be. I saw my mother smile again. But after a few years, we came to the conclusion that the distance was a problem. My mother got other health issues, and they grew apart. My father didn't recognize my mother anymore as his wife. And my mother felt not safe anymore. She got anxious, she got heart problems. So there was a time that I had to go 3 times a week to the place where they stayed to organize some things, to go to the hospital with her, etc. So the situation of my mother was the cause to move them back again in 2015 to the place where I live. And because of the complexity of the situation of my parents, I decided to look for a place where they could give person-centered care, because we came to the conclusion that cultural sensitive care only isn't enough. The quality of the professionals and the quality of the care is more and more important when the disease progresses. So I'm very glad that I have been able to find a place where they were welcomed, where they feel at home, where they get the need, care, and attention what they need for at that moment. And if the staff has any problems, they call me. I am standby 24/7 after all these years, but it works. And I'm very glad that I met someone finally that had the attitude of, you don't have to be ashamed, you don't have to feel guilty. The disease, dementia, doesn't make a difference by cultural background or religion or whatever. Our staff is used to take care of people who are not able to communicate anymore. It's not a problem that they're Turkish, Muslim, whatever background they have. And it's even not a problem for us that they are incontinent. I was ashamed of the situation of my parents. I almost accepted the fact that there were nursing homes where they were not welcome. And that that was very difficult to accept, because it caused a dilemma for me as a person, in the way, why is the healthcare system not ready for this group of patients? How is it possible that they're the forgotten group? They're not second-class citizens or aliens. Why does it have to be such a struggle to organize the care they need? But I succeeded, and I'm very glad.
I was going to say. Yes, thank you for the brief of the brief look on the situation you experienced during the years, and it was interesting that you make the difference between cultural sensitive care and person-centered care. That was a new aspect to me. But coming back to the ethnicity. Could you, for the audience, give one or two examples where you really experienced, okay, there is a challenge in having my parents have a Turkish migration background?
Yeah, well, the difficulties started in the home situation, when they needed more and more home care. There was then they weren't living at the nursery home yet, but in the home situation, on their own with home care, and me as a caregiver to help as much as I could, besides my work and family, etc. And with the home care workers, there was always a struggle. There was a struggle in not understanding each other, not knowing enough of my parents to really connect with them, to have the time to build a connection, to show some interest, respect. They're always, when they were in a hurry, my parents felt that. And if they didn't want to take off their shoes, then they didn't they could leave directly, because my father wouldn't let them in the house anymore. If they came and just put a bread on the table and walked on, they said, well, we're not animals you feed. That's not the way you should treat us. So there was a very great barrier between the expectations of my parents and the way the caregivers did their work. Were used to do their work, had to do their work. My mother didn't want to get personal care by a man, and my father didn't by a male person. And my father was ashamed and took pride in the beginning to accept help from a lady. So if there came a man to help a male to help my mother, and a female to help my father, then the question was, why can't they plan it the other way around? Why can't they consider the needs, the wishes of these people in planning, in making a schedule for their staff? Even the times they came to bring medicine, it was not possible to organize it in a way that it fitted to my parents. It had to fit their schedule, but that my parents had an other day schedule based on praying 5 times a day, well, that was not discussable. My parents had the idea that the house had to be clean and tidy if anyone entered the room, but they were not able to keep it clean and tidy. So if they if the home care persons came 7 times a day, that meant that they had to clean it, in their opinion, 7 times a day, but they were not able to do that, so they didn't open the door.
Okay. Thank you. So it's really the small things and not really it's the individualized approach that it's not. Yeah. Did your parents then change, or did the situation change? So did they over the time did the services become more appropriate to your parents, or did your parents lose many of their habits or ideals, needs?
Both.
Okay.
When they stayed at home, I made a tremendous effort to make agreements with the staff to explain the situation of my parents. I got many complaints about my parents because the personnel was at the professional was at the door, but they didn't open the door. They came to help my parents, but my father wasn't at home. That kind of complaint. So I was in contact with the organization to improve the contact between the caregivers and my parents. I was a mediator.
Yes, so the very important and I guess stressful position of being the advocate of your parents, basically.
Yes.
So, but how?
After a while, their situation changed.
Yeah.
Things that were a problem in the beginning were not important after a while, because their day and night rhythm changed. It wasn't a problem anymore for my father by whom he was helped by taking a shower. So with the progress of the disease, some values and some norms, cultural tradition-based things changed as well.
So the course of the disease requires different strategies and causes different challenges or solves some challenges. How did your social environment react, or what were the expectations from your social environment? Or did you get help for a specific situation?
No, I felt very abandoned and by the social environment. It felt like a very lonely struggle in an isolated place. And I was grateful that the geriatric nurse was there to help me and guide me through the process, because the family kept their distance, was prejudiced, and just just judging me for being a bad girl and a daughter that had to act different. In their opinion, I could have taken my parents into my house and organized or stop working even.
Yeah.
That's what they expected from me to do. And I didn't, because I was aware of the fact that I wasn't able to give them the care they needed. So I looked and asked for help and organized the care they needed, because if they were okay, then I was okay. I was in a dilemma continuously. When I was with my parents, I felt guilty towards my own family, husband and children. And when I was at home, in my thought, I was with my parents because I knew they're not safe. They cannot handle the situation on their own. There's going to happen something really soon, and I have to provide involuntary admission. I want them to be together, to move together, and stay together as long as they can.
Thank you, Gülec. it shows us, or it touches me, since how long you said, more than 17 years, 20 years you have been caregiver, and it's still such an emotional event, and we can hardly imagine how stressful it was back then, when you'd actually you were struggling with the community or with the social environment. Thanks for sharing this.
Yes, you're
welcome. And because sometimes we talk a little bit very high above what's really happening, and do not really realize what's behind when we say it's a caregiver burden. No, it is something that really changes your life, and there should be more support, the support you were missing. And if it's okay, I would like to introduce Aklak to the session, because he's experienced in the work with the community with ethnic minorities. That's one of the reasons we invited him, because he goes on the next level, and he can share with us what can be done in a community, or what are the challenges in communities. I've heard him speak about this topic before and liked his outspokenness and enthusiasm. And please, can you introduce yourself and give a little brief intro of your work? Aklak, please.
Hi, good morning, and thank you very much for inviting me to be part of this panel today. I like the fact that you like my outspokenness, but I also assure you that sometimes it can not win you many friends in certain places. And I say this because, as we've just been listening to Gülec, and thank you very much, Gülec, to share that personal experience. For me also, it's about bringing together the various aspects of our own lived experiences. So my grandmother had dementia before, well, actually I was studying for a master's degree. She died. A year later, I started working at social services, and I used to hear that, particularly from white colleagues, who would say, well, English is a second language. And I used to think, well, actually, I'm Yorkshire born and bred. You know, my schooling is here. I'm at university. My father was teaching me English before I even started school. So how do we fit all this together? So then I'm looking at my experience through my work, which has been working with the minority communities around dementia care, so people living with dementia. I'm currently final year a student researcher undertaking a PhD, and as a founder director of an organization called Meri, Yaadain, which means My Memories. It's a community interest company, but that in itself tells us, where we don't have a word for dementia, we have to find things that our communities can almost like latch onto. So memories was important for us. But what I would say, though, is there are lots of things that are common across all our communities, but often it's about this equity and equality. How we get to that equality might mean that we have to be equitable first. What can we do that's different to be able to support everybody fairly? So that's a quick kind of nutshell of who I am.
So, well, thank you. So the personal experience, and having heard Gülec's experience, how familiar, even though she is in the Netherlands, but how familiar does this sound to you? Does this match your experience? And well,
actually, I think there's just so much. It's almost quite intense, really, listening to the various. And not just from Gülec's experience about her parents, but listening to Dianne's presentation about the intercultural care just shows us the complexity of what does it mean to provide care for people who are not second-class citizens, but are often made to feel perhaps that they are second-class citizens. And why do I say this? It's because we have to work much harder to access information, to be able to get a diagnosis. Often you need a diagnosis to be able to get secondary care. If you're not aware of dementia, how do you even get on that rung of ladders to be able to get that support? Accessing information is often very difficult. There is lots of information out there, but actually when we look for something ourselves, it's often very hard to find something. So we need somebody to help us navigate systems and navigate, particularly if things are on the internet. Then I'm also looking at things that might be different for those of us who may be second, third, possibly fourth generation, people of migrant history or of heritage, is that our elders may have experienced racism, prejudice. They may see unconscious bias in the way they are being supported, but it's often a lack of support. So how do we bring all this in? So that's why, on the one hand, you have stigma that the communities have, and that's at various levels, on an individual family basis, on a extended family basis, and on a community basis. So you know, that guilt that Gülec talked about, absolutely. You know, should I use this service? Is it my obligation? You know, is it a duty of care? What does my faith say? So all these things tend to complicate things. And then if you are then faced with services who think that you're okay to look after your own, you don't need help and services, you know, they think you all look the same and sound the same. I've often sort of mentioned that, you know, we differentiate people across Europe about different nationalities, ethnicities, cultures, foods, languages, but we can put South Asia together, we can put the whole of Africa together and the Caribbean. So that tells us something about how we have an us and them when it comes to support.
Okay, and yeah, you're totally right. But and coming back to the community, what are we talking about when we say community? I mean, aren't we living in all kind of different communities? And so, what's your approach there? What community is responsible, or what community should take the lead in giving access, information, or what are approaches there?
So I think, again, this would be something that needs a multifaceted approach. And again, why do I say this? Because there are different levels of both need and of awareness. If you have, you know, a family level, a neighborhood level, it could be the individual family, that if they're not aware of dementia, what is their social construct? So they might think that it's part of the normal aging process. They might think that, you know, these are some of the things that Dan talked about, that it might be that they feel this person's been punished by God for having been a bad person. The carer might be feeling that they're being punished because they're having to care for somebody that's really immensely difficult to care for. And not understanding what is dementia, because also don't forget, many of the carers of migrant heritage may have moved from well, either they're born in this, what we would call the host country, and their parents may have come from the original country. As migrants, we may not have experienced caring for older people living with dementia. So for many people, it's the first time that generations are having to provide that care. What do we do? Who do we go to? Who do we turn to for help? You know, there is an emotional aspect here, psychological impact, a social impact, you know, and who can help us provide that culturally competent care. So I think for us, that complexity really arises where carers are almost influenced by the people around them and what they say. So when you ask me about the community, yes, again, lots of us want similar things across our communities, irrespective of our background. But then certain communities may have different influences or variations in terms of, what does my faith say compared to your faith? Do I have a faith? Do you have a faith? It might be that there's a transition in the generations. Is the younger generation adopting more what we might call Western sort of values of nuclear families? I've got to chase my job and my family, whereas somebody older might feel that they've got to put their family unit before the individual needs and wants.
Okay, thank you. So this is it's always adding complexity. That's the big problem here. And people always ask, well, then this is, yes, it's interesting. Yeah, you're right. But would you say that there, or do you know of any community, any model of good practice where you would say, well, this is a quarter, a small city, or that you are aware of where everything is in place like you would like to have it?
Well, maybe I should put that in a nutshell by saying I walked away from my day job, and you know, again, you said about being outspoken. I think for me, it's not about being outspoken; it's about being ethical yourself and what are our own principles. You know, my grandmother died with dementia, not having had a diagnosis. My parents weren't supported as carers because the view was that they look after their own. When I look at what is available, there's a huge postcode lottery, as we tend to refer to these things. Depends on how commissioners see things. So often we might see that, you know, funding for minority community work across the board, not just with dementia work, it is both time limited and funding limited. You ask about good practice, and I would say this as a founder director of Meri, the CIC, that, you know, we have national awards. You know, I've been honoured enough to have had an MBE from the Queen in recognition of my work with minority communities where we support somebody living with dementia or the carers. And what we're wanting to do is to replicate and again, what I would call not rocket science. What are the simple steps that can be taken? And you know, people might refer to this as person-centered care, but I think it's about understanding the complexity around the individual. So for some people, it might be about person-centered. For other people, it might be family-centered or relationship-centered. Who are the different people that might act as a next of kin for different reasons and different support aspects? Rather than saying, well, you know, bureaucracy, the form says that I only want space for the next of kin, and that's the person that I should work with. I also think, very quickly, if I may add, that, and this has been touched on by Dianne again, is that there needs to be a stronger, more powerful, more vocal voice for carers, particularly from ethnic minorities, to be able to share their lived experience. I work with a chap called Mohammed. You know, he's a former carer. He supports my PhD, and his experience to raise the voice of carers adds value to my learning. And hopefully, as the PhD is concluded, the recommendations should be stronger than yet another piece of work that perhaps just sticks in a journal.
Okay, well, thanks, Aklak. This is already giving us the direction where we should look at, and Gülec has given her experience. You have said it's a complex issue. You have to look at all kind of levels, but there must be the policy change. And I would like to go to the third panelist, who is then taking back a little bit more focus on one piece that should be improved. And I would like to turn to Rune Nielsen from the Denmark. He's a researcher examining issues related to dementia in ethnic minorities, including documenting inequalities in dementia diagnostics and care. He's eager to assess reasons behind these inequalities and develops methods for overcoming the clinical challenge associated with cross-cultural dementia diagnostics. As far as I know, he is PI on several international studies on neuropsychological tests. So we are going on this special issue of people need to be diagnosed, and they need to be diagnosed culture fair. We have already heard many speakers talk about this. So please, Rune, introduce yourself to the audience and let us know a little bit more about your research and your approach and this statement, where it should go. Rune.
Thank you very much, René. And first of all, I would like to congratulate the DZNE on this great project. And also I'd like to thank the other panelists for their talks so far. I have a background in neuropsychology. I've been working with dementia diagnostics and research on dementia diagnostics in minority ethnic groups for about a decade now. And more recently, I moved on to look at the barriers to post-diagnostic care in minority ethnic groups in Denmark. So I would like to thank Gülec for sharing her family story. And I would like to say I've worked a lot with the Turkish community in Copenhagen. And I can relate to most of what you said. I've heard similar stories from many adult children of older people with dementia. And especially, you said that you were being isolated and that the wider family was not supportive as you expected. And I've heard that quite a few times, and I think that's very, very important for us as a system to understand that the approach that ethnic minorities or minority ethnic groups take care of their own, it's not true in all situations, not at all. It's quite the opposite picture actually sometimes. And it puts extreme burden on the adult children, family carers, who are in a double position, providing care to their own families, their own children, as well as their families, or their parents, sorry. So that was just a first thing. And then I'll move on to talk about diagnostics, which has been my main area of research. When I began looking at this in about 2008, there was hardly any knowledge about the challenges associated with cross-cultural dementia diagnostics. Everyone just knew that this is quite challenging across dementia clinics in Europe, and most people didn't realize why it was so challenging. So I began by investigating some of the barriers to making a proper and valid dementia diagnosis in people from minority ethnic groups. And continuing from this work, I've been trying to develop and validate culture-sensitive diagnostic tools, mainly cognitive tests for use in dementia diagnostics. And Dianne already mentioned the RUDES, which is the Roland Universal Dementia Assessment Scale. It was also mentioned by Tim, which we have done quite a lot of research on, and it's now implemented in several European countries, and also mentioned in the national clinical guidelines, also as mentioned by Tim. But we also developed many other tests that can be used both by neuropsychologists working with diagnostics, but also other healthcare professionals working in clinical settings. So more recently, as I said, I've moved on to look at the post-diagnostic care. And here we have done qualitative work with family carers, dementia coordinators working in primary care, and trying to find solutions also to how to solve some of the issues mentioned by Gülec, because in my opinion, and as Aklak also mentioned, this is not rocket science. We just need a dialogue. What do we need? What's needed? And how do we provide it in the best manner? And I think that that's what's lacking now. People are not communicating. And when they are, it's turning into a struggle between work schedules and individual needs. So I think we need a better dialogue about the needs of people with dementia and their families, and especially with a migration background from minority ethnic groups. And then I think it should be possible to solve some of the challenges.
Okay, well, thank you, Rune. And I think, yeah, communication and is one key. And if I might ask about the diagnostics communication is, for people not in the issue, it is hard to understand. So what's this cultural unfair in diagnostics? So can you give us an example of, I mean, I can just translate a cognitive assessment into a different language. So is that cultural fair? Or
no.
how do I make it? How long does it take? And what are typical examples what to do wrong?
Well, the typical example of what to do wrong is to either translate a test from English to a target language and then expect it to be the same test of the same difficulty, that assess the same functions, same cognitive functions. That might not be the case. Another typical mistake to make is to assume that applying a test that's non-verbal, that's not based on language, is culture-free or culture-fair. That's also not the case. So it's actually a rather long process to develop a test that can be applied across cultures or languages, or to adapt a certain developed test for a different culture. One example is, for instance, the mini-mental state examination that's been translated and adapted for several different cultures and languages. But when using, for instance, the English version of the mini-mental state examination and translating that in situ with a face-to-face interpreter, you're being asked to repeat a sentence that says, please repeat after me, no, ands, ifs, or buts. But how do you translate that in a proper way to a different language? A meaningless sentence, really. So that's really challenging. Also, in many of our tests, we ask about geographic regions, national royalties, politicians, and how do we expect people with migratory background to answer to these questions, having lived in the country for maybe 5 years? So there are many challenges.
Okay.
We
And
need to develop better cross-cultural measures.
yeah, and I hear you pointing at that participation of the people who are actually targeted in those questionnaires is one key to really see what is in the culture, because we usually do not know as coming from a different culture.
Exactly. And another challenge I'd like to mention here is that most of the cognitive tests used in dementia diagnostics are based on knowledge from the school system. So it's based on knowledge you obtained through education. And many of the older migrants who came to Europe as working migrants, as probably the case of Gülec's parents, although I don't know, they came from often rural areas in the country of origin with little education. So they might not have obtained the knowledge required or the skills required to solve like basic cognitive tasks, relying on mental calculation, drawing, reading, or writing.
That's important. That's an important aspect, especially since I like that you had the little sentence, "I do not really know," when talking about the lower education, because that is one of the stereotypes you do that, because there are, for example, in a university city like my Greifswald, there are lots of people migrating to Greifswald, but academics. So we have the ceiling effect with those if they grow old and if they do cognitive testing. So even though in those little questions, we are already tempted to not look at who are we really targeting. So thanks for this. And let me move on, please, to panelist number 4. Rune has already implied that diagnostics is important, but it is just the key, the gate to diagnostic and to care and treatment. All other speakers have said that as well. As panelist number 4, I'm delighted to introduce Sadia Parveen. She is from the Center of Applied Dementia Studies at the University of Bradford in the UK. And among her research interests is one focusing on diversity and dementia, particularly the experience of minority ethnic communities. Sadia was awarded a prestigious early career fellowship from the Alzheimer Society already 2015, and she won the Researchers Leaders Award for patient and public involvement, so coming to the participation part here. With her broad research interest, she has been active throughout the whole patient journey, from diagnosis to palliative care. Please, Sadia, introduce yourself, and we would be happy to hear your thoughts and insights regarding the topics of today. Sadia.
Thank you. Hello, everyone. So as mentioned, my name is Sadia Parveen. I'm a senior research fellow at the Centre for Applied Dementia Studies in University of Bradford. I'm a health psychologist by background, and my main interests are how ethnicity and culture influences the experience of living with dementia. As a health psychologist, I'm particularly interested in how people perceive dementia, how they manage living with dementia, and how we as
worried about what's going to happen in the next 1 or 5 years, but we're really concerned about ensuring sustainability in the longer term. It seems to us that
I'm not talking. I'm not talking. I don't know who's talking, but did we lose the? Oh, now I can't hear you anymore, Sadia.
Both risks and
we hear a male voice talking, not anymore, and we do not hear you. Still, we do.
Someone else started speaking.
Now you're back.
Yeah, someone else started speaking and I was very confused. So as I was saying, I'm a health psychologist by background, and I'm interested in how people perceive dementia, how they cope and live with dementia, and how service providers can support people to live well with dementia. Now, Rune talked a lot about the diagnostic tools, and I have to agree that's one area that researchers have spent a lot of energy on, translating different diagnostic tools into different languages. And as Rune mentioned, that's not necessarily the best way forward. Things have to be culturally adapted on a deeper level rather than just language. A lot of work has gone into dementia awareness. I think where the gaps are within research and where I'm particularly interested in broadening the research is the prevention aspect. So there's quite a few risk factors that are higher amongst minority ethnic communities, such as diabetes, cardiovascular disease, and these are all risk factors that can be reduced and can prevent people developing dementia, and these all can be targeted at a relatively early age, and it's work that we can do now. Another area that needs a lot of work is post-diagnostic support. Now, ACLAC will be able to tell you of all the wonderful things that happen in the community to support families living with dementia, but I will tell you in research terms, none of them are evidence-based, and we, particularly in the UK, lack evidence-based interventions to improve people's lives when managing dementia and improving living with dementia. And there are some studies that are happening in countries such as India and Pakistan where we're finding a good evidence-based for things like domiciliary care, home care, and even CBT. But however, within the UK and in Europe, we lack the big, large-scale trials to provide an evidence base for care packages, really, that support people to live well with dementia in the community, and that's a big gap in the research. I myself am very interested in the experiences of carers. Having been a young carer myself, I related very much to Gülec's story about how you suddenly become the naughty daughter if you don't support your family members. I've been through that myself. And I've looked a lot at that cultural value. In research, we call it filial obligation, so a family obligation to look after your parents. And yes, a lot of minority ethnic communities do buy into that cultural value, but research shows that those who have higher levels of cultural obligation to provide care actually have poorer health outcomes later in life. So they might experience higher levels of burden, higher levels of anxiety and depression. So actually having that cultural value of looking after your own is not an advantage to minority ethnic communities. It can actually be a massive disadvantage. And there's been a lot of research in America with African American and Korean carers, and I've done a lot of research in the UK with South Asian carers, and the research consistently shows that those carers who feel a cultural obligation to provide care have poorer health outcomes, and we need to better support those carers to provide care that meets their needs but also meets the needs of the person living with dementia. Another thing I want to highlight is people mistake the cultural value of looking after your own as a willingness to care, but actual obligation and willingness are two very different things. And we're finding those carers who feel the obligation to provide care are not necessarily willing, and that can have an impact on poorer health outcomes later. And then finally, just because someone is obligated to provide care doesn't mean that they are prepared to provide care, doesn't mean they know how to support someone with dementia, doesn't mean they know how to look after themselves. And those are important things if we are to support families to live well with dementia.
Well, thank you, Sadia. You have introduced another topic now, because you introduced the health of the caregiver. So we're getting even more complex, and I struggle a little bit with we need more evidence-based caring in studies. Can you elaborate a little bit on how to answer those cultural questions in there? I mean, providing appropriate treatment and care already is a challenge, leaving out the cultural issue. So how can we appropriately include them in studies? Do you have a study that you are proposing, or what an example how you could answer this?
So myself and Professor Rick Cheston at University of West England are currently leading on a study called the ADAPT study. And what we're trying to do is to develop a culturally adapted toolkit, particularly for South Asian families. And what we're trying to do is look at the different interventions that are available to not only diagnose people living with dementia, but also the post-diagnostic support angle as well. And what we're looking at is what already exists for people and how best can we culturally adapt these things that already exist to meet the needs of diverse populations. What we're finding is that there's lots of support already available, and it might have had some cultural adaptation. Most commonly, people just translate things, which we already know is not the perfect way of culturally adapting something. The messages have to be culturally relevant as well. But we actually need to know whether these interventions work before we go to the effort of culturally adapting them to a deeper level. So, for example, is a course, an online course for carers that teaches them effective coping strategies more effective than sending someone from the same background as you to provide you support with care at home? Which one's most effective? And then the one that's most effective should be the one that's culturally adapted and made more widely available. That's what the study focuses on, and that's what we're trying to achieve with the ADAPT study.
Okay, so you will, for example, try to find an answer whether to provide those navigating the system, let's say, by a person with Turkish heritage in a Turkish community. Is this really necessary, or are those other factors? Perhaps it's more the person-centeredness, but the cultural. Like I don't remember who did it. I think Dianne said it. It's the attitude, it's the openness that might be even a way out the ethnic background of the care provider. This would be the kind of question you would come up with an answer, so that we are not led by our own thoughts and prejudices, but more evidence-based and see what's really counting. I think that's very much needed, since coming back to the EU Atlas a little bit, it is when we get into more detail, more and more questions arise about the things we did. You mentioned diagnosis of dementia. Tim has, and Jessica has calculated the number of people affected. We took the prevalence data from the countries where they reside in, but now it's not even clear whether the risk is higher for people that have moved. We do not know whether the risk is higher of people who have moved from a regionally underdeveloped area. So very much is just not known that could lead us in the future. And thanks Sadia for this statement. Coming to the next and final panelist, I welcome Sirpa Pietikäinen, a Finnish politician and member of the European Parliament from Finland. She is a member of the National Coalition Party, part of the European People's Party, and has been a member of the European Parliament since 2008. So I suppose that she's experienced when it comes to policymaking. She's a member of in several committees for various topics. She will introduce herself in more detail, but I just wanted to point out the aspect on which we decided to invite her. She states that she is committed to the idea of a Europe with a human face, a Europe that guarantees the respect of human rights, equal opportunities, social inclusion, and access to high-quality services. Basically, very much of what we had discussed and said put in one sentence already. This is a broad issue in which we integrate our today's discussion: equal opportunities, social inclusion, access to care. Sirpa, please let us know a little bit more about you and give us some comments about today's topic, discussion, and perhaps even an outlook on what needs or will happen the next years.
Thank you very much, and thank you for inviting me to this very interesting and important panel. And besides of that, what I do professionally, I worked with memory disabled people and organizations over 20 years, and I'm a caretaker, part-time caretaker of my mother who has Alzheimer's, and she's 97 years old at the moment, and has been living with the condition now over 20 years. First of all, let me sort of start with this sort of a principle. We shouldn't label, because the racism or discrimination starts that you can label people, the Iraqis or the Turkeys or the Finnish, the woman, aren't we saying, or the memory disabled people are like this or like that. So we would need to have the diversity and understanding of the personal differences, always on the background. And this is what I'm reminding to myself and then to others. And that comes to Sadia's very good comments, what I heard. We need to, at the same time, very carefully to understand the cultural differences and preferences that are part of our personalities and the traditions. But so not to sort of try to duplicate the models what we are having, let's say in Great Britain or in Finland, to Sami people or the Somali people, or that matter gay and lesbian people. But then again, to me it's important to avoid that kind of a thinking. Okay, Roma people have the tradition of taking care of their own elderly people, and lets them do so in the future too. Because there might be the cases, as Sadia quite clearly underlined, that there isn't that warm relationship. There's not the willingness to care, nor the willingness to be cared by the another one. So we would always need to have the diversity on the bottom and try to respect the person having the care, whether there's the preference of having more community-based care, maybe that kind of a care home system care, or family-based care. That seems to be the best possible and most preferential to many. But as at the same time doing myself, I would want to underline it's not for everybody. No one wants, not all people want to be cared at home, and not all children or spouses want to do it. And if there is not that balance, you do not create a good care and good living conditions, and the home care, the community care home base could be better. But so all in all, to summarize, take all the diversities. We have gay Roma people in Finland, or we do have very independent Turkish people in Germany who want to live by themselves or whatever, and try to listen and tailor the system based on community care so that you could pick and choose with the respect of a person that kind of a care facilities and services, what suits best for that person and to their family. I don't know if I used too much of your time.
No, that's fine. That's fine.
But I just want to limit here.
You can go on. I'm listening. I think all the others are listening as well.
Okay, because I was not sure because I saw your picture.
No. That is just
that was a sign.
The technicians sometimes zoom me in and zoom me out. I don't know the exact reasons for that as well. So this is not a stop sign for you, because I would like to have you talk a bit more about the. So it's not a national, a regional challenge. It is a European challenge. So what can Europe do?
Challenge, and that's why we would need to have a European supporting systems. And there are still 3 points. But then, if I have time, I would like to raise. One is that still quite a lot of people are going to want to choose, or if they want or not, if they are single, for example, they have to choose a care facility, care home. We need to ensure that we have a specialized care homes with adequate people with Turkish or Roma or whatever ethnic background to serve the people coming from that background. Because knowing by definition the memory disabling diseases, you might lose the language you learned the latest. You might be more sort of bound to your own language and your own habits. And then if you do not have that kind of a connection, it can be really isolating and worsen the conditions. And there's a study of Sami people in Finland that showed that clearly, that people thought that, okay, they are in a severe state of dementia already, but then they had someone talking and dressing original Sami clothing, and suddenly there was a revival of a commentary and understanding, because there was the cultural linkage. So, and that then reflects what kind of a people, and in general, this is with elderly people and hospitals, you would need to recruit much stronger the people with immigrants and refugees and varied ethnic backgrounds, as well as sexual preferences background. Then the second point, and that is the support to home. And there we would need to have that kind of a linkage as well. And I was thinking which way the carriage and horse is going, when Sadia said that quite often they are much more burdened than in worse condition, the caretakers of people coming from different cultures. Is it how much the fact that they are not in favorable economic position compared to the existing population, or that the caring itself is heavier? I think it is that difference of the general economic income level. And that's why we would need to pay special attention to tailor that kind of early support for caretakers and the advice for that kind of a community services to be used hand in hand, and to take care of the health, and this is both the physical and mental health of the caretakers, because being in foreign culture, not your native culture, and with heavy caretaking responsibility, can really take a heavy toll on people. And that's why we would need to sort of tailor a European-wide, and I hope Alzheimer's Europe and we all others could continue working on this to create a sort of a specific tailored program. I hate the word minorities, because we are all minorities. Depends on whose perspective you look at. But for, let's say, diversity care needs of memory disabled people, be it disabled, be it sexual preferences, religious backgrounds, ethnic backgrounds, or whatever that is, and to treat the people more like individuals, as what we do. Thank you.
Okay, well, thank you. This is quite an approach. And again, we are talking about words. Again, we're talking how we are not supposed. We must be careful in labeling, but yet we need something to call. To know that what we are talking about. So now we started with migrants, with our presentation on the Atlas. We moved from migrants to ethnic minorities. Now we're in diverse populations. So I think this already shows in this short presentation what kind of a development is needed or undergoing right now. I have introduced all of you, all have said some sentences. Now this is open for discussion, and I know that it's difficult in this format. Is there anyone who wants to comment on what has been said so far? Just raise your hand or just raise your voice. Otherwise, I will move on. Oh, Rune, please.
I think we all agree that it's really, really important to improve this field and improve clinical and care practices. I think what's really needed is both at a political level, at a practical level, and at a research level to find the best suitable solutions. And I say it in plural because I don't think there's one good solution for larger groups of people. And as it's already been mentioned, that we might need specialized care services that are able to work in a culture-sensitive manner. And we have a last discussion about whether we need specific services or we can implement aspects of this in mainstream services. And I think we need both. And besides that, we also need services that support the family carers in supporting the relatives with dementia at home. I know in Denmark that service is not available today. It doesn't exist. You can take the public services, but you cannot get in-home support to provide services or to provide support yourself. And I think people from minority ethnic groups have many different preferences. So we need to have a wider palette of offers across Europe.
Yeah, so there are many ends where to work on, basically, and yes, acknowledging diversity and already knowing that it is not one size fits all. It is okay if there is a huge migrant community, perhaps specialized facilities is the way to go. However, there are regions where even those ethnic minorities are a minority underneath minorities, so it would not make sense to do specific services there for this ethnic minority, but cultural sensitive services. So defining the picture, what can be done, and provide the support for the caregivers is basically I think the common denominator. Someone needs to support the person who is dealing with dementia or who is caring for the person with dementia. Any more thoughts, Gülec? You have listened to all of us talking about the situation, our research, and did you have anything to add? Anything you would like to raise?
Well, it's nice to hear from the experts and to see that there is so much knowledge available. What I would like to add is that I've come to the conclusion that dementia, the diagnosis of dementia, is not the end of their life, not the end of the life of my parents, neither the end of my life. So it's a road you walk together, and it's very important to take care of the caregivers as well. So I'm very glad to hear that there is the attention for that group as well. And I've learned that it's important to focus on the similarities instead of the differences. To focus on what is still possible instead of what has been. So, well, if the dialogue starts, then there is. I think that's the beginning of the solution. And somewhere during the process of dementia, cultural sensitive care can transfer to person-centered care. So dementia is a disease in progress, and so should the care that is given to the person with dementia fits at the stage they're in. So it's not a packet that is a package that is the same during the whole period. The needs can change as well.
Yeah. So thank you. So thank you for this statement, and I think that's for us that's a reason to go and do further caregiver-oriented research, to further say, okay, it's not done with the diagnostic, to look at the whole trajectory, to look not just at the person with dementia, but look at the supporting system, look at this professional supporting system, and try to optimize there. Aklak, do you want to say some statement or some last words, some summaries?
Yeah, I think excellent what we're hearing. And again, I take this back to the fact that you can have so many different hats that you wear, but it comes back to our own lived experience. What is it that we can do as an individual, as a family, as a group of friends, in the society that around us? So what comes to mind for me are three things here. One is that there's an imbalance of power. Who's leading the dialogue? Who's having the conversation? who then acts as the gatekeeper. So who decides what support you can have, what care package you can have. So that is about gatekeeping in itself. So when I talked about unconscious bias, the second thing here really is to think about the use of what we often hear as community leaders. When we talk about communities that we don't understand, then we look for leaders in that community. And we could call them experts, but I would much rather refer to the term champions. Those are people who can use their lived experience, to use their voice to kind of share the experience and hopefully influence that decision making. And thirdly, the term, again, this is a difficult one that I struggle with, is when people talk about they are hard to reach. Well, nobody's hard to reach because those communities are there. And this is about maybe services starting to reflect on the fact that they themselves may be hard to reach. What do they need to do to be able to engage with communities, to listen to stories, to listen to lived experience? We often talk about, my own organisation. We're a very small organisation in Bradford, in West Yorkshire, in the UK. But actually, we're having all sorts of conversations locally, nationally, internationally. But if I was to talk to you about are we commissioned and who listens to us, well, we're a small voice. So what Sadia said is really important. It has to be evidence-based practice so that people who would otherwise not listen to you will listen to you because then you're in policy and documentation and research.
Well, thanks. Very, very well said. And I think the first time we said, okay, we were not recruiting people, we are engaging. We are engaging in the. I think that's important. And sometimes we lose this view. And I'm glad that you mentioned the term champion as well, because I know that's rather UK based, but that fits very well what you've been talking about. Thank you, Rune. Do you have a statement or some last comment?
Well, I think, as mentioned by Sadia earlier, also a lot has happened regarding research and diagnostic tools, but we're really lacking looking more into the post-diagnostic care, what happens after the diagnosis has been made, when people are going back to the community, back to their families with an hopefully early dementia diagnosis, what support is available and what support is the best. A lot is going on also at a European level in terms of harmonizing the use of diagnostic tools in minorities, both language and ethnic minorities now. We have an initiative called the European Consortium on Cross-Cultural Neuropsychology with members from several countries, looking into best practice and both at an organizational level, but also looking into research in developing suitable diagnostic tools. So a lot has happened here. Also regarding the work of medical interpreters, as Dianne mentioned earlier, there's a very, very large gap in our knowledge and in clinical practice in many countries and clinics. Family members are used as relatives also during the diagnostic process, which is highly challenging and problematic, in my opinion. So we need some kind of good guidelines or regulation of the use of medical interpreters, both in clinical settings, but also in care settings.
Yeah, thanks for pointing out the post-diagnostic care as being very important and not to be left out or neglected, especially since the press is full with aducanumab and the treatment, and tends to go away a little bit. The people have the feeling that everything is solved now. Sadia, please, the sentence, a statement.
I actually have two quick points to make. So I've heard people use the phrase person-centered, culturally sensitive, family-centered, and I would argue that if you are truly person-centered, you would meet that person's cultural needs. If you are truly focused on that person. So we throw that word around a lot, but we need to think about what it means. And if you focus on that individual, you will not only meet their cultural needs, but you will also involve the family if that person wishes. So we need to think about why we are person-centered with the majority population. So I'm from the UK. Why are we person-centered with white British families? But when it comes to South Asian family in front of you, why are we thinking they're South Asian, so what do I do differently? Why can't we be person-centered with them? My second point, which I don't know if people have mentioned before because I had some technical difficulties, the only way to improve dementia care is by research, and research really lacks the involvement of minority ethnic communities. We as researchers and as service providers need to better engage with people like Gülec and make sure that research is addressing their experiences and how we can improve services for them.
Well, thanks a lot. That already points to the last statement of Sirpa and our expectations that we will keep on going on a European network, start to do European, start to collaborate, start to have, like Rune said, European consortium to tackle this. And Sirpa, please give us a last statement. Where the time is just about over. What's next? What should be done? What's your take?
I think that we should have this frame where we call that the target is to have enabling person-centered living conditions and service structures for all memory disabled people and their relatives when they are included. And that needs to include the cultural and other diversities. So enabling and diverse are the two words that I would like to have there. Second point, that you know that in rare diseases, we do have the European reference centers. And now with the new European EU for Health program, there's the plan that we would have from non-communicable diseases, the reference centers. And I hope that you as researchers and specialists would firstly establish among yourself and start demanding from the Commission. I'm strongly supportive, and I know there's a lot of MEPs and organizations for you, that we would have a reference center for memory disabling diseases. And as a part of it, we would have this acknowledgement of a diversity and needs for diverse services, including ethnicity, cultural backgrounds. We'll need to remember that there are different other kind of cultural backgrounds. Someone might like the classical music and be a composer, and someone hard rock and be a hard partier. And for them, you can't put the same hat either. So then just to really sort of put that sort of a deciding on how to create that service so it's inclusive for all different kind of people, and not as it happens that you set aside the minorities or ethnic back people thinking that okay, they take care of their own needs. Thank you very much, and hope to be part of this discussion when it continues.
Well, thank you very much. Thank all of you, all the panelists. Thank the Robert Bosch Foundation and the other talkers. We went over time. I'm sorry about that. I just want to say the whole presentation or the whole day will be available, downloadable on the internet. So if you want to listen to some of the aspects afterwards, please do so. If you are interested in keeping up the network in research and providing, I don't know what the word is to use right now, but basically on the topic we were talking about today, I think we should come up with networks and we should start the European Reference Center. Those seems to be some structures and some ideas that will develop and that we will participate in the next few years. Thank you very much, and this event is over. Thanks Gülec, Aklak, Rune, Sadia and Sirpa.